Hi, welcome to the 2020 Academy of Oral Surgery's Fall Symposium. I'm Dr. Carlos Fernando Mourão, the host of this program, and today I'd like to introduce our special guest, Dr. Vishtash Brumad. Dr. Brumad is DMD and MED from University of Florida. He's our maxillofacial surgeon, along with an additional year of general surgery at University of Miami Jackson Memorial Hospital in 2003. Dr. Brumad, he's one of the most important oral maxillofacial surgeon in the US and well-recognized oral maxillofacial surgeon in Arizona, Phoenix, Arizona. It's a great pleasure to have you here today, Dr. Brumad, and the floor is yours.
So I'm going to get started. Once again, thank you for Norris Medical, and thanks for everyone here for being with us. So I spend a lot of my time in my practice doing a lot of zygomatic implants. Obviously, dental implants are something that are booming in dentistry, and I've devoted a lot of my time to reconstruction of the severely resorbed maxillas. And a lot of my patients come in with failed all-on-fours. Here you can see the pictures from one of the courses we did at my office, where we had some participants come in, and obviously they observed me doing a live surgery. I was placing some Norris zygomatic implants. Hopefully in the future we're going to have live courses in the office, because in Arizona we can get a 1-week hardship license for anyone to work on patients as long as they have an active license somewhere in the States, but that's down the road. So let me, without further ado, get started here. Let's see if I can advance my slide. There we go. So this is what I used to do in the past. You see a patient here that I did a sandwich osteotomy. We took a piece of their hip, shaped it like a horseshoe, and basically we anchored that into the maxilla that was very atrophic with dental implants. Well, a lot of times we put undue pressure on there. The patients would have resorption, and nonetheless, sometimes these work, sometimes the implants would be left with very little bone down the road. So it was not the greatest and the best restoration or surgical option for patients. Now, of course, you can see on the right of that, there's patients that have double zygomas with a couple of anterior implants if they have adequate bone anteriorly. And of course, on the bottom, you see the quad zygoma, which has been around for quite some time. And we're going to spend some time on that today to talk about these options. So where did all these angled implants come from? Obviously, the first one was pterygoid implants. That was developed by Dr. Paul Tessier, and they've been very successful, but that's been talked about during many Norris seminars, and I encourage you to go look at them. There's some great lectures that some of my co-presenters have done, and pterygoid implants have been talked about quite a bit, and I think there's one tomorrow too. Then there's, of course, D-long zygomatic implants, first developed by Dr. Granemark, who was an orthopedic surgeon. And like I said, these were initially designed for reconstruction of head and neck cancer defects, and now we use them for dental rehabilitation of the dental crippled patients, as I call them. These are patients that have nowhere else to go other than massive bony reconstruction, but that's a big surgery itself. And of course, the tilted implants, the so-called all-on-4, all-on-6, whatever you want to call it, and that has been more and more common amongst our dental colleagues worldwide. And like I said, there's lots of patients that do tilted implants, all-on-4s. Sometimes these cases do very well, and unfortunately, there are some patients that develop failures, and as a result, in the maxilla, there's not much of a choice other than doing zygomatic implants sometimes. So when do we do zygomatic implants, and when do we do an all-on-4? So zygomatic implants are basically indicated in an edentulous maxilla in a patient that does not want bone grafting and major reconstruction, where there's only bone in zone 1, or as I call it, the premaxilla. So here, if you look in the middle of the screen, the premaxilla is this area here. If you only have bone in zone 1, you're not going to be able to do an all-on-4. You're looking at an all-on-2. So if there's no bone in zone 2 or 3, or there's only bone on one side, then you're looking at a patient that has only alveolar bone anteriorly, so you're going to have to do zygomatic implants on this patient. Or you're going to have to do sinus lifting on these patients and do conventional implants if they don't want to undergo zygomatic implants, but that's a long, lengthy process. So keep in mind this slide as I'm going to show it again later. So if you're missing the bone in zone 2 and 3, you're looking at the option of zygomatic implants. Now, there are some patients that are deficient even in zone 1, and basically their nasal floor is coincident with their oral mucosa. In those cases, you don't have a choice but doing the quad zygoma. There is no other option. So going back to the zygomatic implants, Dr. Brandemark first did cases with these back in the 80s and 90s, and of course throughout the year 2000 there's been many studies, and they've basically shown a 95% success rate over time. And some of them fail early on. Sometimes that's surgical technique, sometimes there's complications that develop. In my own hands, I must say I've had 1 to 2 failures a year, and when I go back and look at them, you can always find out what caused the failure. Sometimes it's a patient, sometimes it's restorative failure, and sometimes it's surgical failure. But nonetheless, when these implants are done properly, the failure rate is very, very low. The success rate is just as good as conventional dental implants. So what are they indicated? So here is a typical patient that I would see in my practice, someone that has severe atrophy of their maxillary complex. And you can see the floor of the nose is almost coincident with the oral cavity. Now, some people are doing them for patients with moderate atrophy. Like I said, this patient only has bone in zone 1, quite deficient in zone 2 and 3. You could probably try to get away with an all-on-4, but nonetheless, the success rate for the zygomatic implant is just as good, if not better. And no atrophy. Some people are using zygomatic implants in combination with pterygoid implants for patients that are deficient in just, the width, height a little bit, but they can use a quad zygoma or zygomatic implants with pterygoids and anteriorly in the vomer region to do zygomatic implants. So there are a whole host of indications. Now, the newest technology is available to us. And what we found through lots of research and trial and error is that maybe the success rate for zygomatic implants can be even better through an extramaxillary technique, because the traditional technique was the intramaxillary technique, as you can see on the left. And now with the extramaxillary technique, we have found that the implants have a better success rate, and the surgery is quite more, I would say it's easier. It's not as cumbersome. So I have, in my first 10 to 15 years of doing these, I did almost all intramaxillary or intrasinus. And now I've gravitated towards the extramaxillary technique for a number of reasons. I find that the restoration is in a more, I would say, appealing or position for the patients. There's not as much palatal bulk to it for patients. And of course, the head of the implants comes out in a more favorable buccal position on the alveolar crest if it's done correctly. But in order to basically understand the difference, we're going to go through some cases. And like I said, I encourage you to go back and watch some of the webinars that my other co-presenters for Norris Medical have done. These are all available on YouTube, so I'm not going to belabor some of the points that they have gone over in the interest of time, but there are indications for each one. And sometimes when I do a case, I do a combination of one implant in the intramaxillary position and one in the extramaxillary position. Some people, based on the Zaga classification, they let the anatomy of the zygoma dictate where they place the implants, but of course the anatomy of the sinus is just as important. Some patients will come with a very large pneumatized maxillary sinus, and that dictates the position of the implant as well. So here I'm going to show some cases at first that I've done that were the intramaxillary technique. So here's a quadruple zygomatic implant for a failed all-on-4. So I see lots of patients with atrophic maxillas. A well-meaning surgeon will place, an all-on-4, and of course, what happens is they don't always last. See, if you take a look here, this patient is only 45 years old. The floor of his nose is basically paper thin. This patient has failed 2 all-on-4s, and there's not much left for this patient. So obviously, if you look at this patient, the anterior maxillary wall is very, very concave. There's not much left. The infraorbital nerves are pretty much right there. Now, if I was to do this case now, I would have done the extramaxillary technique, but this case is at least 10 years old. So at that time, I was doing the intramaxillary technique, and you can see in order to have the implants come out in a favorable position, I had to use very long implants, and my cantilever arm was quite long. Going back, this patient, his restoration would come undone once a year, and we have to go back and tighten it. So, through trials and tribulations, we learn from what we've, done in the past. So this case that was done in an intramaxillary fashion would have been more favorable to do in a extramaxillary fashion now. And like I said, we'll go take a look. So this is a quadzygoma I did on this patient with an immediate conversion. So this patient obviously had a restoration on the same day. Now, what's interesting about this case is you can see young gentleman, strong masseters, strong muscles. He was a clencher. He had a lower overdenture, which was failing, and we did offer to have him come back and have a lower all-on-4. Actually, just last year, I was going to place 4 to 5 implants to all-on-4, and this patient decided to go overseas because the cost was a fraction of what we could do it. So I caution patients when they go anywhere overseas to any other country, if they're going to have something done, make sure they're able to go back if there's a complication, because this patient did develop a complication. You can see the bottom restoration came out with the implant in it. So now he's back to square one, unfortunately. But, you always have to be prepared to deal with your own complications. That's why I tell all my colleagues, or when I do my courses, if you're going to do a surgery, either be prepared to deal with a complication or know who to send it to fix it for you. Now, here's a case where I did a combination of pterygoid and zygomatic implants for a very atrophic maxilla. Here you see this gentleman. Looks like he's got a combination syndrome. Almost looks like a class 3 malocclusion because he's 50 years old, has been wearing a denture his entire life. And he obviously came across some funds, and he was able to come in to have surgery done, to get this procedure done. Here you can see, if you take a look, this gentleman has lost at least 1.5 centimeters of bone in the anterior maxilla. And how do I know that? Because if you look here, that incisive papilla that used to be way up here is now all the way down here. So he's lost all that bone. This is a tough case because, this gentleman has been wearing a denture for a long time. He could no longer wear a denture because his maxilla was so flat, there was no retention. So what do I do for him? Obviously, preoperatively, what we want to do is measure the lower half of the face. We measure the nasion to progonion, and you really want to not change their vertical dimension. Their face is going to change a little bit, but you have to make sure that you don't make too many changes because you're going to affect their speech, you're going to affect their appearance, and some patients that's not what they want. So what I do here is my incision is a hemi-Lefort type. But keep in mind, if your incision is too far to the palatal, you're going to have a hard time reflecting that mucosa over, and you might tear it. So my incision is mid-crestal, but more towards the buccal on these cases. Now, keep in mind, this is a intramaxillary case I did, but that becomes so much more important when you do the extra maxillary technique, and I'll go over why. But remember, so the crestal incision is more to the buccal for easier reflection, and you're going to have a vertical release posteriorly, close to the malar buttress, because if you don't release close to the malar buttress, you're not going to be able to dissect all the way up to the zygomatic arch. And some people release their incision anteriorly. I go paramidline. I don't release the incisive papilla there. I've had a few patients over the years that had incisive nerve damage from previous surgeries, and it's quite painful. So I avoid the incisive foramen altogether for that reason. But remember, you must expose the malar buttress, and you want to stay away. You want to stay away from the inferior aspect of the malar buttress. So here you can see what I've done is I've exposed the malar buttress here, right? Now, if you go into this dark area down below, if you go underneath it, you're going to hit the infratemporal fossa. So we try to stay away from the infratemporal fossa and the attachments of the superior portion of the masseter muscle because you can get into some bleeding. Most of us are doing these surgeries in the office. Although I know lots of colleagues of mine that are overseas, they do this kind of surgery in the hospital, and they don't load the implants right away. But it's become, quite common for us to do these in the office because the patients want to have immediate gratification. They want to leave with teeth, and it's kind of hard to do dental lab work or have acrylic flying everywhere in the hospital in the operating room. They just won't allow it. That's why, for me, this is an office-based surgery. But no, I want to minimize the chance of any hemorrhaging or any bleeding. Now, if I do get into bleeding there, when I've gone into the infratemporal region or if I've cut the masseter, I have a Bovie, we have Surgicel, we have Avitene at our disposal, which is microfibrillar collagen. But nonetheless, you have to be really cautious when you do your soft tissue dissection. You're going to go along the inferior and frontal lateral surfaces of the zygoma. And like I said, the two areas to avoid are the infratemporal fossa, and of course, more importantly, is the orbit. So, as I mentioned, let's always respect the masseter muscle and the orbit. Here you can see following the zygomatic dissection, the maxillary sinus is fenestrated because, I'm actually, my initial goal in this patient was to do a quad zygoma. And I changed my operative plan and I did a zygomatic implant and pterygoid implant in that area. But if you could see here, this is a traditional intrasinus technique. I made a 10 by 5 millimeter infrazygomatic window because you keep in mind that when you do the traditional intramaxillary zygomatic implant, it's a blind procedure. So I urge everyone that is doing these surgeries, you need to master both because sometimes you have to make changes in the middle of surgery. And you need to know that when you're doing the traditional zygomatic implants, it's a blind dissection. You need to know your anatomy very well and just in order to avoid getting in trouble. But here you can see that I'm keeping the Schneiderian membrane intact. I'm reflecting along the lateral superior portion of the zygomatic arch. And going back a couple of slides, on the left-hand side, you see the zygomatic notch retractor. So the zygomatic notch retractor is something that obviously this is the one that I developed myself. I do every single case with this retractor. I encourage you to either use a retractor that you can, get into that frontal zygomatic notch. Otherwise, you can't see where you're going. You don't have to expose the notch completely, but you want to make sure that the tip of that retractor, which is down here, is into that zygomatic notch. And I'll show why. But this is one that I developed myself a few years ago. I'd say about 10, 15 years ago. There was not a big market for zygomatic implants at the time, so it wasn't produced, although now it's being sold. But nonetheless, you can use an Ovigazer, or I think there are lots of other comparable products. So following placement of the implants, then we did take our hybrid temporary prosthesis, and I have a lab in my office with the prosthodontist or general dentist, whoever is doing the conversion. They are working together in cohort to do an immediate conversion. So what happens is patients that I do the surgery on, I find the success rate is so much higher from every aspect when the patient leaves my office with fixed teeth. I know some people like to perform the surgery, put on these white or silver comfort caps and have the patient come the following day to have the teeth installed. Once you master this procedure and you do it at a fast enough pace, you can do it all in one day. This surgery should take no more than 3.5 to 4.5 hours. I remember the first one I ever did took 9 hours, and it was an absolute nightmare. But it was my very first one, and it was a little over 20 years ago. But when a patient comes back the following day, they're all beat up, they're in pain, they're bruised. I'll show some pictures of what the patient looks like the next day. They don't want to sit there in your chair to have you take off these caps and put on their restoration. So I would encourage you to do your temporary hybrid the same day, not the next day and not the next week. I evaluate the occlusion intra-op, but remember they're under deep sedation or general anesthesia. So the bite may change. So I immediately check it again post-op, and at 1 week myself, and at 1 month myself. And during that time, they can see the restorative doctor as many times as they want, but I make it a mission for myself to see him immediately, 1 week later, and 1 month later. And I don't give the green light for the final restoration for at least 4 months. Some of my colleagues go even 6 months, but it all depends on the primary stability I get. Now with the Norris implants, because they have a deeper cutting, more aggressive thread pitch, the primary stability and torque values I get are far superior to any product I've used in the past. So I feel more comfortable doing the final prosthesis at 4 months than I did before. But this is my patient immediately and at 1 week post-op. You can still see he's a little bruised. There's some bruising at the nasolabial region. So you can imagine what he looked like immediately, but he's pretty beat up. But a very happy capper nonetheless, because he went from having a denture to a horseshoe hybrid immediately. You can see here the positioning of one of the screws is somewhat palatal. So is this one here. So that's what happens with the traditional technique, because you're going from the underside of the zygoma to get anchorage of that implant. Sometimes what happens is you do not get favorable palatal position. And I will be the first to admit, I've had a couple of cases that I wouldn't want to show because they were too far to the palate. Actually, over the last 18 years that I've been doing these, I've had one implant that was too palatal that I actually had to bury the implant and basically abort that implant because on the day of surgery, we were able to load it, but it was too far to the palate and it was not what I wanted for my patients. This is the final impression that my prosthodontist is taking. Basically, on this case, at the 6 month mark, you can see there's 2 pterygoids, there's 2 zygomas, and 2 anterior implants. You can see they use the blue mousse to do a pickup and verify the jig and to make the bar. This patient had a fixed restoration fabricated, like I said, 6 months later, and his is the final restoration. Looks pretty good, and even though the position of those screws is somewhat palatal, the patient did not complain because it certainly beats having a denture, but you and I all know that we want to have them in a more favorable position towards the buccal. And that's one of the reasons why I've moved away from the intramaxillary technique towards the extramaxillary technique. So you go from a denture to that. That's really nice. And this patient has a wonderful smile now. At some point he's going to come back for the lowers. This is the final restoration. So I do have patients that come to me who have gone through numerous reconstructive efforts in the past. And what we find is when you do a big sandwich bone graft or onlay bone graft from the hip to the maxilla, over time it can resorb. This is a patient that had a Lefort osteotomy done at a very young age for an ectodermal dysplasia. So, about 40 years ago, he had a hip graft done to his anterior maxilla, and you can see that how deficient he is in the picture where he's wearing a blue shirt compared to the other one. It looks like he's typical class 3. His chin is almost completely ahead of his lip, upper lip. And look on the left side, he's got zygomatic implants and a restoration in place. Look at the smile. It's a world of a difference. This patient went from having a very flat malar eminence to a full malar eminence and a full cheek, just with 4 zygomatic implants. So you go from something like this on the left, where a Lefort osteotomy, you see the screws and plates that were there from 20 years ago. I didn't have to take them out. I avoided touching them. This is still the intramaxillary technique. And just with 4 zygomatic implants, we changed this patient's appearance and his life. So there are lots of techniques out there. I tell patients, yes, you can have bilateral sinus lifts, you can have a hip graft, but the results are not immediate and they're not guaranteed. So I'm going to show you cases where I've had patients that have come to me, they've already had failed restorations done elsewhere. This patient came in with quads, like I said, it's all trials and tribulations. What I found from the very first case that I showed you with a 40-year-old man that had 4 zygomatic implants and his restoration came loose was the long cantilever arm can be beat by placing one implant anteriorly. This is what I've done for some of these cases. Here's a case, like I said, looks like a combination syndrome, very deficient maxilla. So if I can find some room up front, either in the vomer or in the premaxilla, to place one implant, I can defeat that rocking. Because what happens is these things tend to loosen. The screws, you have 4 little screws holding in a big restoration. So here, what I did is I placed one anterior implant, and that avoids the need for a patient coming back in once a year to tighten the restoration because it's getting loose. The patient that I showed earlier who went overseas, he actually had his own screwdriver, and which is not what you want because they can do some damage to the implants and screws, but he was tightening his own screws once a year. His restorative doctor gave it to him. So this is what I have learned, and I'm sharing that with you. If you can, the goal is always to have one implant somewhere up front to prevent that lever arm, the strong lever arm. These are 52 millimeter implants. So then, we have some cases that are failed traditional implants or even failed zygomatic implants. Those are always the toughest ones to deal with. So here I have a patient with an atrophic maxilla and a failed failed all-on-4 zygomatic implant. So here you see the patient had what appeared to be something, a nice restoration initially. When the doctor did these zygomatic implants at that time, they were anterior, but the apex of the implant wasn't so low like it should have been. So it kind of blocked out a lot of the rest of the zygoma for placement zygomatic implants, and like a second one. So I actually had to crisscross these. And, there are some indications, some cases where you purposely cross your zygomatic implants, but there's no right or wrong way to do it. You just have to keep in mind when you cross your zygomatic implants, you want to look at the sinus angle and obviously the orbital. The orbit always is very crucial. You want to avoid a collision with your other implant as well. So not only are we trying to avoid the infratemporal fossa down below, we're trying to avoid the orbit. We're also trying to avoid the other implants. So in this case, this patient had one implant free floating in the nose, one that was in the vomer and broken off. So I had to come up with a way to basically save the case. So we basically placed 2 additional zygomatic implants in a more posterior position, but they had to be crossed in order to be in that dense zygomatic bone because the alternatives were not good. I mean, this patient had no other choice going from a fixed restoration. She did not want to be in a removable situation. So up to this point, I think I've done a lot of reviewing of cases that I've done with the traditional intramaxillary technique. And basically, with the new Norris medical system, the cases are so much easier to do. And many of you that are listening today and watching may look at some of the cases I presented and saying, well, this might be a little too hard for me to do. Well, it's not. With the new, with the Norris medical, it's really so much easier. And I'll go over the case, I'll go over the surgical setup, and we're going to dissect the case from start to finish so you can see how much easier it is. So if you have any questions, please feel free to email me or send me an Instagram message. It's Brugman Oral Surgery. I know a lot of people reached out to me on the Instagram to get the login for the course. But if you have any questions, I'm available via either one of them. So the extramaxillary technique, how is it different? Let's talk about this. So with the extramaxillary technique, we're taking advantage of the anatomy of the zygoma and sinus, placing the implant in a more favorable position. The body of the implant, depending on the Zaga classification, can be either touching the zygomatic, the antral wall or the sinus, or in it, or completely outside of it. If you're doing a double zygomatic implant, sometimes that anterior implant, you have no choice but to have part of it be in the sinus. But based on what I've seen, these implants are you can use them in the extra or intramaxillary approach, and sometimes you don't have a choice. Like I said, the anatomy of the maxilla and zygoma dictates what you do, and of course, the pre-op CT scan is most crucial. But this is a very highly predictable system, very high success rate for an atrophic maxilla. So going back to that, this is a slide just to kind of tell you some information about the Norse medical system. It's placed via the extramaxillary protocol, which is a modification of the traditional Brandemark technique. I mean, many of us that do Brandemark implants have had to place their implants in an extramaxillary fashion. That's why they came up with implants to be used in an extramaxillary fashion. But the problem with their implants is sometimes the diameter of the implant body and tip is very different, so you have a hard time placing them. With the Norse implants, the great thing is the diameter of the implant is 4.2 millimeters all the way up and down, so that makes life a lot easier. The body of the implant is very smooth, so it prevents damage to the sinus membrane, and the zygomatic implant is very aggressive at the tip. So the cutting edge has deep fluted burrs, and you get very high torque values, and I'm very comfortable loading these implants right away. And unlike the previous intramaxillary implants, where sometimes you had to get bicortical stability, the tip of your implant stuck out a couple of millimeters, you don't have to do that with the Norse implants. And I'll show you some great cases. What I find now, what's interesting is with all those previous cases that I showed, most of the abutments I used for those are 17 or 32 degrees. And the reason for that is because the implant's kind of palatal. Now, because the implant's in a more favorable buccal position at the crest, my most common go-to abutment is the 45-degree angle abutment, although you can get them anywhere from some 17 to 60 degrees, but I rarely use the opposite extremes. So it's especially designed, the implant, like I said, for the extramaxillary approach. The length is available anywhere from 30 to 60, although the 60, I believe, is not FDA approved in the US yet, but I have yet to need anything longer than the 57.5. Internal connections is a traditional 2.4 millimeter internal hex. It's a Zimmer type connection. So, actually I've had a couple of cases where, I've actually noticed that my restorative doctor, and I wouldn't advocate this, but he had used a Zimmer component because he ended up dropping the screw on the floor and didn't have the screw, so he was able to use a Zimmer screw in the middle of surgery. But what's great about the smooth body is there's no chance of attachment of the sinus membrane to it. Even in the best case, I've had a couple of patients that I did the intramaxillary technique, sinus membrane was completely intact. Patient developed a sinus infection 4 or 5 years later. The sinus membrane was adhered and scarred down to basically the implant body, which was treated with threads and had a very, very, I'd say, adherent surface. These are RBM treated surfaces of the threaded part, which increases the part of the implant that grabs the bone. So like I said, 2.4 millimeter internal connection is pretty standard. And the sharp and deep threads, I can't say enough about them because the primary stability you get from these implants is second to none. It's very, very impressive. And you'll see a couple of cases that I'm going to show you following this. So what's the advantage of this technique, the extramaxillary technique versus the intramaxillary technique? Well, the biggest advantage is, first of all, the surgery is so much easier to do, but the prosthetic platform is shifted to a more buccal favorable position. So that way your restoration looks like a typical hybrid all on four. So the patient isn't going to feel this bulky plastic in the roof of their mouth. Sometimes some of the zygomatic cases that I've done or I've seen done by others, the restoration looks like a denture just missing a small part of the palate because the implants are so far to the palatal. And that's not what these patients want. The surgical kit, this is one of the older kits. It has a medium and a longer burr, but the burrs can be anywhere from 30 to 80 millimeters. So to account for the different heights and size of the zygoma. Going back to this slide, this threaded portion of the implant is about 16 millimeters long. Why is that? Because that's going to be the average length of that zygomatic body that you're going to enter. So basically, at the very worst case scenario, even if you're longer, you can have at least 16 millimeters of threaded implant in the body of the zygoma. It tapers to 3.5 millimeters up at the apex, but it's a gradual taper. Some of the other systems out there do not have a tapered implant, and what happens is in the process of performing your osteotomy, sometimes you lose primary stability. So the great thing about the Norris system is sometimes you can slightly under-prepare your osteotomy and let the cutting flutes of the implant do the rest of the work. But nonetheless, and this kit has the biggest game changer. These diamond burrs have made our lives as zygomatic implant surgeons so much easier. And it comes in a coarse, medium, and fine. And I'll go over how to use these. But the kit is very nice. This is the smaller kit. There's a more premium surgical kit as well. I think I have a picture of that. It's grade 5 titanium, very biocompatible with excellent tensile strength. These implants will not fracture. So keep in mind, if you have underprepared an osteotomy, the chance of you fracturing the implant is very low, but you can fracture the zygomatic arch. Remember, most of us that are treating facial trauma, we see lots of zygomatical maxillary complex fractures because oftentimes that patients get hit in the face and they can fracture the zygoma. So keep in mind, you can also fracture zygoma when you're placing the implant. As I mentioned, these implants go anywhere from 30 to 60 millimeters. I have yet to need the 60 millimeter implant. Now, there is a cover screw that comes with an implant. Why is that? Because sometimes when you place your implant, you have a lip of bone at the crest that prevents you from placing your abutment, so you put the cover screw in there to smooth out that bone without damaging the internal surface of the implant, and then you dispose of the cover screw. So as I mentioned, the implant is 4.2 millimeters for the whole cylinder. The diameter at the apex is 3.5. Comes all the way from 30 to 57.5. And now this picture is the drilling sequence. It's quite important. Now the burrs come, there's 3 different sizes, small, it's, I would say 1, 2, 3. The difference is the tip. So if you take a look at this, there's also a depth gauge there. The depth gauge is also very helpful when you're trying to orient the orbital line, because if I place my anterior implant first, I want to make sure I'm away from the orbit. So I use this depth indicator as a good guide, and I'll show how I use it in the case coming up. But what's so unique about these burrs, the 1, 2, and 3? First of all, I rarely use the third one. So if you look at that first burr, the diameter at the very tip is 2 millimeters. Remember what I said, the tip of that implant at the apex is 3.5 millimeters. So the first 4 millimeters here is only 2 millimeters. 4 millimeters in height of that burr. The second 4 millimeters is 2.5 millimeters. The third portion between 8 and 16 is 3 millimeters. So even if you drill with your first burr to full depth, your osteotomy is still much smaller than the head of your implant. So 90% of my cases are drilled with burr number 1. So if I go to place an implant after I've done my first burr osteotomy, and I get a lot of resistance. And actually, I had one case, the very first Norris case I did, I underprepared it by half the length of the first burr, and I felt like I was going to fracture the zygoma. So I always use my first burr to full length. So the first burr goes to full length. If I go to place this implant and I get too much resistance, I'll take the second burr. Remember, the second burr, the first 8 millimeters is only 2.8 millimeters. Still 7 millimeters less than the tip of your implant, which is 3.5 millimeters. So I will drill this. You can drill this to half the length if you don't get a lot of resistance. But remember, the second portion is already 3 millimeters. It's the same diameter as here. I've only used burr number 3 one time, and that was an extremely dense D1 zygomatic bone. Remember, the middle portion of the zygomatic bone is that cancellous bone. It's still pretty dense, but we're interested in that zygomatic bone that's very dense, the D1 bone. Nonetheless, you rarely ever have to use this last burr, the full length. And if you do, you could lose primary stability, because remember, this implant, this burr is 3.2 millimeters here. So keep in mind, in most of my cases that I show, the burrs that you see are burr number 1. Rarely do I use 2, and hardly ever burr number 3. This is the surgical kit once again. This kit is an older kit. It does not have a round burr in it. The new kits now have a round burr, and they have 4 lengths of burrs. This is the surgical kit. It comes in, like I said, the step drills. I call them forming burrs. And of course, the diamond burrs, which is 4.2 millimeters. They're 30 millimeters in length to account for the shortest implant. And this will create the groove in your antral wall. This is shows the step drills. There's the 40, 60, and 80 millimeter ones. And now there's a shorter one as well, which is 30 millimeters to account for the shortest implant. What's great about these step drills that no other system has is it has depth markings. So this basically works as a depth gauge as well when you're placing the implant. Now keep in mind, I have my own zygomatic notch retractor that I use that's sitting in the zygomatic notch. So if the tip of my burr hits that retractor, I know to stop, and at that point I measure my depth. That is not my final depth. That just gives me an idea of the size of implant that I'm going to use. But like I said, burr number 1, I rarely have to go beyond burr number 1. Remember, at the tip, it's 2 millimeters. The first 4 millimeters are 2 millimeters. Now, these zygomatic burrs for preparation of the groove have changed the zygomatic implant world. They really have. So these so basically this diamond burr is used to create a channel all the way from the crest to the entry point into the zygoma. And they have basically changed the way we do implants. They have changed the way we do zygomatic implants. The coarse, gritty one is obviously the first one you use. So what I do is I take a round burr and make a pilot hole into where I think would be the correct trajectory, of course, to avoid the infratemporal fossa and the orbit. And then I use my coarse, gritty diamond to deepen a groove in that area. And you always have to check your orientation. This is a stock case. I'm going to go over my cases in a few minutes. But the multi-unit components are very, very easy to use. They come in numerous heights. And what happens is with the traditional intramaxillary ones, a lot of those implants had a carrier. Once you took off the carrier, it was very difficult to reposition your implant. With the Norris implant, it's quite easy. So if you place your implant and you're off by half a turn, you're not happy with the position of your multi-unit abutment, you can basically move your implant a quarter of a turn because the carrier is quite easy. It's and then you place your multi-unit abutment and you can torque it down. You'll see what I'm talking about when I present the case. Here you can see you can use straight or multi-unit abutments. They go all the way from 2 to 5 millimeters in height, and the angulation goes all the way from 17 to 60 degrees. You hardly ever have to use a 60-degree one. Like I said, I usually live here between 45 and 30. These are their tough implants. So if I'm using an anterior implant, I would place a tough implant. If I'm doing a combination with a pterygoid case, I'll use the pterygoid implant. It's got a smooth, polished color to account for that thick tissue and the retromolar tuberosity region. Now, what's great about the system is you have these guide pins. So, it's happened to all of us where we open up an abutment, it's not the right abutment, so you waste an abutment because you're not happy with the angulation. Well, here you have these sterilizable guide pins that you basically put inside the implant to make sure you're picking the right abutments. And, I value these because that way I don't go through unnecessary abutments. Similar systems, like I said, are Nobel. Southern Implants, just lost about the systems out there, but these are the other two competitors. And like I said, I've moved away from everyone just because Norris Medical has made my life so easy. The implants are quite easy to use. This is the drilling protocol. Obviously, contraindications to placement of zygomatic implants are an acute infection of the maxillary sinus, history of pathology or trauma, and of course, you have to inform these patients that there are risks. You tell them that there is a risk for development of sinus infections. With the intramaxillary technique, obviously, was higher. There was also a risk of developing cutaneous fistulas, and you have to, even though hopefully it's never happened to any of you, and it won't, but you have to tell them the orbit is close by. because an informed consent is the most important part of these zygomatic implants, and it can keep you out of trouble. I have yet to find a good zygomatic implant, an informed consent out there, but I've made my own. I'm more than happy to share it with anyone if they want to email or send me an Instagram message. But your zygomatic implant consent should be different than your traditional dental implants because the risks are far different. So I'm going to go over the drilling protocol in a second, but the prosthetic phase is no different than your traditional all-on-4. Now, what I do tell my patients afterwards is I always tell them, if you can't cut something with your finger, you can't eat it for 3 months. And that will eliminate the risk of failure in these patients. So I always tell them, I say, the risk for failure goes down if you follow my direction. So for the most part, these patients know that if they can't cut it with their finger, they can't eat it. So the restorative phase, as I mentioned, is no different than a conventional all-on-4. If you have a good laboratory that you work with, things can go streamlined and they're quite easy. But I do an immediate loading for all my cases. So once I place the implant, I place the multi-unit abutment. We put a non-engaging cylinder over it with a lab screw, and then my lab and my restorative dentist take over. So basically, the cases are converted every single time in my office. The patient does not leave the office without a temporary hybrid. This is a clinical case. It's a stock clinical case, but I want to show how the groove preparation proceeds. So here you see the coarse diamond burr being placed into a entry point here. So this entry point was made with a round burr. In my own cases, it'll be a little closer and the quality of pictures will be a little bit better, but nonetheless, I want to show you. If you do visit the Norris website, you'll see some of these pictures, and it's very self-explanatory. But what you see here is the surgeon is preparing the groove without violating the smagnary membrane. Look at that. It's not perforated. And then you can push it back with a periosteal elevator and place your implant into the recipient portion of the zygoma. Now, if you look here, this surgeon has a Selvin retractor. I don't see a zygomatic notch retractor, but I always have a zygomatic notch retractor in the zygomatic notch. And that way, I see exactly where my implant's going. You don't have to expose the zygomatic notch for every single case, but you should definitely know where the tip of your implant's going, and you should be aware of that. And because it's very easy to get confused and place your implant close to the orbit, and that's definitely a no-no. Here you're correcting the angulation with a 45-degree multi-unit abutment. As I mentioned, this is a smooth body of the implant, and you can correct that with a 45-degree abutment. Here you have 2 zygomas and a pterygoid. That's going to give you great primary stability. So some surgeons will use bone graft material or HA to cover this body of the implant, the cylinder portion, so patients don't place it. I don't do that. What I do is I free up the buccal fat pad and bring it over and close it to the midline, and I get great results with that. And that way the patients do not feel that the body of the implant. You could do a bone graft, but nonetheless, with HA, I've had a couple of cases over the years I've seen the HA break and fragment off and then become secondarily infected. I learned that early on when I was doing head and neck surgery and doing facial fractures, that HA cement can fragment off. And if it does, then it becomes a foreign body and risk for infection goes up. So keep that in mind. The product that you're using up there needs to be something that is stable. That's why I use the buccal fat pad. And the buccal fat pad obviously is something that we all know how to use. We use it to close oral antral fistulas. But it's interesting. I'm going to show a case where we use the buccal fat pad to close a fistula from a zygomatic implant. So at this point, I'm going to move on to my clinical cases. And nonetheless, like I said, feel free to email or send me an Instagram message, the Brugman Dual Surgery, and I'm more than happy to answer them. And follow-ups if you're interested in future courses I'm going to be putting on with Norris. So this is actually a course that I put in with Norris Medical. We did this course in Miami. It was a cadaver course. It was great. We had about 15 doctors some surgeons, some restorative doctors, and we actually got to place pterygoid and zygomatic implants on cadavers. So we had a great turnout. Obviously, with the pandemic, we had to postpone some courses that we were going to have now, but we'll have some in the future. This is another one. This is a one-day course that we did in Miami again, that we did on cadavers. This is another one that was very successful. We did a live lecture and cadaver course with my partner here, Dr. Garg, and of course, this is the retractor. This is the retractor that I was mentioning to you guys. If you're interested, Osteolife Biomedical sells them. I don't get anything from it except, I guess, my name lives on through the retractor. I don't even think it's named after me. Nonetheless, it's a retractor that I designed years ago with KLS Martin, and they were not interested in producing it because back then there was hardly any surgeons. There was only 100 surgeons nationwide doing zygomatic retractors, doing zygomatic surgery. But now it's very, very common. It's a great procedure and great service to our patients. Once again, like I said, you'll be able to see this later on online. So now I'm going to show you a case for a quadruple zygomatic implant for failed all-on-4 and with an atrophic maxilla, just like I did before with the intramaxillary technique, but now it's with Norris implants, and you'll see a difference. This patient comes to me, very young lady in her 40s who had 2 failed all-on-4s. It's quite unfortunate because, these all-on-4s, if they're done properly early on, and someone with a robust amount of bone shouldn't fail. But nonetheless, it failed. And I think sometimes you have to keep in mind the patient is the biggest risk factor for failure of implants. So I've actually added to my informed consent that if the patient alters the restoration, I am no longer responsible for the implant. So actually, I've had a couple of patients over the years that I've noticed they altered their own restoration with a nail file because they didn't like the shape of the teeth. Well, these implants aren't designed to take those lateral forces a week after surgery, and they can fail. Nonetheless, you can see that I did this case in my office. This was done under general anesthesia. I have my anesthesiologist in my office. The patient gets intubated for this case, but I don't always do intubations. Some of these cases that are done with an open airway, and of course, you can do it with just deep sedation. It can even be done with local anesthesia, but obviously, I have my patient's comfort in mind, so I don't do these with local anesthesia. And I don't do my own sedation when I do these zygomatic implants. For a conventional all-on-4, I do my own sedation for single arch all the time, but with these cases, I tend to shy away from it. Here you can see the pre-op. She's got a deficient maxilla in zones 2 and 3, and she's got a very robust zygomatic arch. It's a little flat laterally out here, but it's pretty robust. There's plenty of room there. So remember what I talked about with my incision. So incision is key. It's a crestal incision to the buccal. Okay, now you can see here that my incision is mid-crestal more to the buccal because that way it allows you to release, get better reflection, and I do a vertical release posteriorly. You saw the vertical release posteriorly behind the tuberosity that is aimed towards the malar buttress. My anterior release goes all the way from the nasal floor down to the crest. My release is, I have 2 releases anteriorly, you see that. So I keep the incisive papilla intact because I want to avoid any issues with nerve pain. I've seen it in the past. And I want to have something to close my buccal fat pad to. You'll see how that works. So avoid your incision into the vestibule as well. That's very important because I've heard of a couple of cases where someone released their incision out here in the vestibule and they damaged the parotid duct. That can happen where you damage Stensen's duct. So keep that in mind. Always be aware of your anatomy. And because remember, you have to expose the malar buttress to get all the way up to the zygomatic arch. So here you see pre-op markings. I mark every incision before I make it. I make this with a sharp 15 blade all the way down to periosteum. And you develop a full thickness mucoperiosteal flap because all the vital structures that can be damaged are within that flap. So as long as you don't tear your periosteum, you're okay. Here you see I make a full thickness flap. I reflect it with a sharp periosteal elevator, and that way I avoid damage to any vital structures. Lighting is key, and you have to see what you're doing. So I expose my malar buttress all the way. You can see here I expose it with a periosteal elevator. The Minnesota retractor goes up there. And if you look on the very bottom, here you can see my zygomatic notch retractor pop. If you dissect this properly, it goes right above the zygomatic notch and it pops right in there. Obviously, if you're too far up, you can pop into the orbital rim easily too. So you have to look on the outside and feel. I always look, I always listen, and I feel, obviously, because you listen for that pop into the zygomatic notch, and you feel that to make sure you're not in the orbital floor. Because that zygomatic notch retractor, if it's aimed in the wrong direction, you can get into the orbital floor. And I know a lot of my colleagues talk about points, lines, angles, or the orbital line or the sinus angle. That's all fantastic. You have to be aware of all that, but the reality of it is everything you look at on the CT has to translate clinically. So here clinically you see that the zygomatic notch retractor will define where I'm placing the tip of my implant. So then what I do is I take a round burr and make a hole on the superior lateral aspect of the zygoma. Now remember, some people prefer to place their posterior implant first, or I call the lower one. Some do the anterior one. What you have to make sure you do is if you're at least 3 millimeters from the edge of that bone here to avoid a fracture, because you don't want to out-fracture your zygoma. That can easily happen. Here you see the zygomatic notch retractor in place. This is that round burr that I make. So here I'm placing my posterior implant place. First, I take a round burr and I penetrate that. Obviously, you might be within the sinus. So if someone has a very large pneumatized sinus, that round burr, that round osteotomy can end up in the sinus, and then at that point your implant is, partially intrasinus. But our goal is to maintain an extramaxillary technique. And see here, we're at least 3 millimeters from the edge of the zygoma to avoid an out fracture of the zygoma. And here I'm avoiding the infratemporal fossa, because remember the superior portion of the masseter muscle attaches here. And you want to avoid damaging that to avoid getting into any bleeding as well. Then I take my coarse diamond burr. You see, this is the coarse diamond burr that's in that kit. And as I said, I can't stress enough how much of a game changer this diamond burr is. It allows you, so you put the tip of this diamond burr into that round hole that you prepared with a round burr, and basically you can move this in a sagittal vector to create your channel. So basically you try to start up here and close to that hole and create a channel, and as you lay your hand down inferiorly onto the bone, you're going to deepen your channel. So remember, if you look at this channel, if I have to describe it, you're creating this portion of the channel first because the tip of that burr sits here, and as you deepen the groove, you're going to create a full channel. And this channel is, you can basically lay a flat instrument in there, you can lay the depth indicator in there, and you'll see the vector of where your implant is being placed. Now keep in mind here, I said I did the posterior implant first. There is no right or wrong way to do it. If you're doing the anterior implant first, you want to be 5 to 7 millimeters away from the infraorbital rim. And your implants always have to be about 10 millimeters apart to give you a good, proper AP spread and good, favorable position. So if you're placing 2 zygomatic implants, you're going to be about 1 centimeter apart. The bodies of the implants are going to be about 1 centimeter apart. But so what you see here is I place the diamond burr, I pivot the tip into that hole and redirect along the path of insertion, and they're at least 10 millimeters apart. So I'm deepening that groove, and you can see here that the part of the buccal fat pad has now popped out, which is fine, because I'm going to take this buccal fat pad and free it up, and at the end of my surgery, bring it over the body of these implants to cover those implants. So as I move away the membrane a little bit from my osteotomy, because I don't want to perforate this membrane, then I take my medium and round and fine burr, and I flatten out the groove. Now what I do, I know some colleagues 3D print their immediate restoration, what I've traditionally done is I have a patient that has a denture ready to go. And once we know the implants have achieved primary stability, we convert that denture into a hybrid, and then 3 to 4 months later, they get their final. So what we do is we have a clear duplicate of that denture. So when I have this clear duplicate of that denture, prior to placing the implants, I make sure the trajectory of my implants, the head of the implant falls within this clear channel. And this clear channel, I've sat down with my restorative doctor or the prosthodontist, and we've decided that these are going to be on, close to the buccal, the portion of the crest. I don't want them to be in a palatal position. So this clear channel, this clear guide is fabricated by my lab. So here you see the posterior implant getting ready to be placed. The buccal fat pad just sits there until we're done with surgery. Here you have the zygomatic notch retractor. The tip of the implant is going to end up here. I don't want it to come outside the bone. So what happens in the old intramaxillary technique, sometimes in order to get stabilization, I apologize, you have to get bicortical stability. So you would have the implant come in through the inferior portion of the zygoma and then go out to the superior cortex. And with those implants that had very non-aggressive threads, sometimes the tip had to come out 2 or 3 millimeters to get good primary stability, and that became a problem itself. And I'll show that when I go over my complications section. But here, you see this cottonoid. Now, what is this for? So I use these cottonoids commonly when I'm doing frontal sinus fractures or orbital floor fractures. I basically soak it with cocaine or soak it with local anesthetic, and it works great for hemostasis. Also, I lay it. So once I push in that floor, this sinus membrane, the sinus membrane, and it's intact, I basically place one of these into the osteotomy site to protect my sinus membrane. What does that do? If the burr happens to catch anything, it's not going to catch that. It won't catch your membrane and cut your membrane, because the goal is to minimize any chance of damage to that membrane at all times. So I gently, you can actually take these are radiographic markers in it, so it doesn't get lost. You can order these in bulk from your surgical supplier. But basically, this is the smallest one that I had available, and you pack it into their little osteotomy. So you see here, it's packed in there, it's soaking up the blood, and I push it in there really nicely. You can almost have it disappear. You don't see it anymore, but it's there and it's protecting your sinus membrane. So when I do my osteotomy, if my burr happens to catch something, guess what? It catches this guy and not the sinus membrane. Because what happens is when you put in this tip of this burr, sometimes you have to redirect and you get close to the sinus membrane, and what you want to do is avoid having to tear that. So this guy is protecting, this cottonoid is protecting my membrane at all times. Like I said, 90% of my cases are done with burr number 1. I hardly ever have to use burr number 2, and rarely ever burr number 3. I think 3 people raised their hand. Let me see. Oh, yeah, I apologize. You're right. It is too late not to see. So I'm showing the surgical steps. Yes, I took out those slides. All right, I will answer all these questions at the very end. So here you see the cottonoid stuck to the burr. I take it off and you can replace it, but at that point you've managed to avoid any kind of damage to the zygoma. I think I got to the membrane. There we go. So now we're getting ready to place our implant. So once again, we drill to depth with our number 1 burr. And the great thing about these implants, or the burrs, is that they're marking the radiographic. I mean, they have the markings are on there, not radiographic. They have printed markings on the burrs. So when the tip of my burr here hits my zygomatic notch retractor, I stop, I look at the measurement, and I kind of have an idea of where I'm going to be. And generally, when I measure the implant, it's about a couple of millimeters, 2 to 2.5 millimeters shorter than this depth, because the tip of my burr slightly comes out and hits this retractor. So if I measure 45 here, I'm probably going to end up using a 42.5 millimeter implant, only because when you put in the depth gauge in there, you're going to try to grab the lowest portion of your osteotomy, because you don't want the tip to stick out, and it's generally about 2.5 millimeters shorter than what I measured there. Here you can see the implant being placed on a hand carrier. The implant placement is not really blind anymore because I have been able to visualize my osteotomy all the way, and my retractor is sitting there and the zygomatic notch safely protecting any vital structures. This is the implant going in on a very high torque value. Like I said, the only purpose for the cover screw is to place it if you need to smooth out any bone. The implant is placed in the proper trajectory, and we have plenty of room to do another implant anteriorly. So here, we place the implant, and of course, you can see here that the tip of the implant is obviously it's coming out. So this is actually one that I wanted to show that we had to redirect because the tip of the implant is coming out the zygoma. So this is one of my very first cases, and the reason I'm showing this is because you can see a little green stick fracture here. If you look at that, this is one when I got a little overzealous, so we redirected that. But it's always important. So you can see here I had to redirect it into a more superior position, and that's really all. What you always want to have that you want your posterior implant apex to be above the anterior implant. That's the only way you can. So I was forced to crisscross my implants here, but nonetheless, I show this because you have to be able to deal with your complications. So when I went to place this implant by hand, because I had underprepared it, you see I got a little green stick fracture here. So we had to I went through the same osteotomy and redirected it. So keep in mind that you can't underprepare with burr one. Burr one, you have to use it to full length. So here we have our implant being placed in the new orientation. And I placed a second implant in the more anterior position. And the tip of this implant is below the apex of the most posterior implant. And then what we do here is we take our depth gauge, measure because I had to take that implant out, then I placed them simultaneously. But I did my second osteotomy first to make sure that I'm away from the other implant. Because what you want to do is you want to make sure that the implants don't collide. But nonetheless, I have to deal with my own complications. So I'm showing this because everyone shows all their perfect cases, and you have to be aware that not every case always goes perfectly as planned, and you have to be able to deal with it. Oh, what would be the optimum torque? Oh, some of these implants, the torque value is above 85 Newton centimeters. Your torque values are tremendously high, and obviously, there's a couple other questions here. What about augmented views by Dr. Balan? Oh, Dr. Balan is great. I watched his webinar. Like I said, I don't augment the facial aspect of my implants with bone or bone material. I have, and I'll show you a case where I did a product from Medtronic that is similar to BMP. It becomes bone, but I just want something that doesn't get mobilized. So what if a virtual system is available? How safely is it to avoid the infratemporal fossa in orbit? Obviously, a good knowledge of where they are with the 3D system is what you want to do to avoid placing the implant into the orbit or infratemporal fossa. As you can see here, I check myself multiple times throughout the surgery with the depth indicator. It goes into the osteotomy site. I feel the tip. I feel it from outside. So before placing the implant, and I'll show this in a second, I'm going to answer these questions in a little while. But you see here, that's actually a great question. How do I avoid the infratemporal fossa and the orbit? So see, after I've done my osteotomy, this depth indicator goes in. The purpose is not only to measure the depth of the length of your implant, but you can also hit the tip of your retractor. And if I take my retractor out, I feel for it with my fingers. I'm going to put my finger outside here digitally and make sure I feel the tip of that depth indicator to know for a fact that I'm in the proper place, that I'm not in the orbit and I'm not in the infratemporal fossa. So if I don't feel the tip of that, then I go back and redirect. Luckily, there's enough volume of bone with the zygoma that you can do that. But the key is to make sure at all times you know where your implant is being placed. So here we have the two implants being placed. And so now, because my first implant, have you noticed here, remember, I took this implant out, right? So this implant, because it was a green stick fracture, I had to take it out. So I dealt with my own complication. And as a result, I placed two zygomas, and they crossed each other. So the posterior implant is always above the anterior implant, and that way you have enough stock of bone to do this properly. Nonetheless, look, the heads of the implants come out in a favorable AP position, about a centimeter apart, and the bodies of the implants are not touching. There's no collision here. So this is the crossing pattern. So you can do if you're doing a uncrossed pattern, obviously your implants are going to be parallel, but here the crossing pattern, which is perfectly acceptable, but you just have to make sure your implants do not collide, because that defeats the purpose and increases your risk for failure. But here you can see that both implants, obviously you can't see it here, but I check myself with this clear guide at all times to make sure the heads of both implants are within the channel. So then we do the same thing on the opposite side. On the opposite side, I reflect my full thickness flap all the way down to periosteum. So this strip of attached gingiva remains completely intact at all times, and you'll see why. So I repeat the procedure on the other side. Now here you can see I have two distinct channels that are separate from each other. But look what I did here. I took my cottonoid and I slid it in there to protect both areas, the Schneiderian membrane at all times, so I don't violate that. And actually that was a very neat little trick that I basically learned from being an oral surgeon. Basically I use that cottonoid for orbital fractures, and when I'm doing frontal sinus fractures close to the brain, it soaks up all the blood. So here it's the same thing. It soaks up the blood, gives me a dry field, and also reduces the risk of penetration. Once again, look what I've done here. So I take after I've done my osteotomies, you guys, before I place that implant, this depth gauge goes in that osteotomy at full length, and I feel it hit the tip of my zygomatic notch retractor. So one of my assistants is actually holding a Minnesota retractor. One of my assistants is using a tongue retractor here, because you have to be able to see what you're doing. So here, I do apologize, jumped. I've done both osteotomies. So for purposes of this, because I'm in the process of writing a textbook chapter on zygomatic implants, I had the photos done, but normally what I would do is place one implant and do the osteotomy for the second one and place that one too. But what I was trying to show here is you can do a double-barreled zygoma on one side without perforating the membrane if you take the necessary precaution. So here what I've done is, like I said, I put in the cottonoid, and that protected me at all times. You could be the greatest surgeon, but if you're not cautious, you're going to make mistakes. And here, in order to avoid damage there, I use these cottonoids at all times. It's a great adjunct. So here you see me measuring, and basically what happens here is this also checks my trajectory. We place one implant, we place the second one, and here you see we have a quad zygoma. On this side, they're not crossing. On this side, they're crossing each other. But look at the position. They're in a very ideal position on the crest of the arch and a buccal position. Now, here on this side, I think I had to remove a little bit of bone here because I caught a lip of bone there. But nonetheless, you can see that you have to do what you have to do to get the multi-unit abutments to sit on there without any bony interferences. So here, I put my clear guide in there again, and what happens here is we check where the multi-unit abutments are coming out within the guide. These are on the right side, and then we do the left side. So then you check all four at the same time. Here you can see the four multi-unit abutments in a somewhat favorable, I think they're in a favorable position. My referring doctor and their restorative dentist, obviously they dictate it. So if they're not happy, we take the multi-unit abutment off and then we replace it. But here you see my restorative doctor is checking the position of these abutments. We're using the clear channel. They're happy with it, so then we proceed with the next step. So prior to closing my incisions, we put on the cylinders, and the lab technician and my restorative doctor start the chair-side conversion here. So this is the final position of the abutments. We check our final position. We check the bite. So basically then they put in the cylinders. This is them pushing up, patient up into occlusion. This is basically a bite registration we had taken beforehand. with the patient's existing denture, because we're trying not to change that, of course. And you can see here, this is going to be the heads of your implants. So by using this blue mousse, so that's what they're doing here. They put blue mousse on the inside of the denture, okay? And the abutment handles have now been taken off, so you only have the abutment heads in there with the white caps that I showed you earlier. So we now check, we know where the position of these implants are. These are really nicely on the buccal crest. Now we can safely remove this palatal portion of acrylic here. They hollow out the holes here to do the chair side reline. The cylinders are kept in place there. Then my laboratory technician, they put in this rubber dam over there and put in the acrylics on the periphery of these cylinders to complete a chair side reline. Now what I did is I took some of the patient's own bone and mixed it with some AOS on this side to put over that area where I had created a fracture on that left side. Normally, like I said, I don't use bone grafting material. I basically put in the buccal fat pad, but in this case, I took some bone and grafted it over where there was a small little out fracture or a green stick fracture on my zygomatic buttress where I had over torqued that implant. But here they're covering the inside of these cylinders, so nothing else gets in there, and then they can take off the restoration after this acrylic is curing, and then they go back and polish it when I'm doing my closure. So here you see packing bone over that area on that left side. They're using the acrylic, flowable acrylic into the periphery of those cylinders prior to removing it altogether. So this is the immediate hybrid temporary. It's nicely polished. All that palatal, obviously acrylic is removed. Obviously, when we do our final, we're going to try to make this in a smaller, more appealing restoration, but the patient is very happy because they go from two failed all on fours and a denture to this. Now it comes to the closure. So while my lab is outside with my restorative doctor polishing the restoration, I take my buccal fat pad and mobilize that. Look at that. It's beautiful. It's got robust blood supply. I cover the entire body of the implant. So while some of my other colleagues use bone, and that's perfectly fine, I take advantage of biology and use your own material, use your buccal fat pad. I mean, some people remove the buccal fat pad for cosmetic reasons, but I believe in saving it at all costs. So here we take the buccal fat pad and I bring it all the way anteriorly. Look at this. I brought this thing all the way to the midline and sutured it because we were able to free it up, and it survives. Obviously, it becomes fibrotic over the body of these implants, but the patient doesn't feel the body of those implants long term, and it's a great service you're providing. Then when I'm done with my closure, I put the white caps back on. My restorative dentist is polishing the final product. So here you see the buccal fat pad is coming all the way from either side and sutured down. Now, obviously, this buccal fat pad is pretty big and robust. It's going to shrink down over time. Then when the restorative doc's ready, prior to waking the patient up, we take these white caps on and put in the restoration. Patient goes from this to this, obviously, and you've provided a great service, and they wake up with a denture. Obviously, this is not the final product. This is the temp. So this is so much easier than the intramaxillary technique. It really is. And I think what's happened in my practice is I basically abandoned the other zygomatic implant systems, and I find that with Norris, it's just a fabulous product. This is, like I said, one of our courses that we had, and this is some of our surgeons that came to our course. We did a live surgery course, like I said. We're able to have doctors get a license. As long as you have a license somewhere else in the country, you can get a 1-week license in Arizona. This is one of our courses we did in Miami. This is Ed and Nikki from Norris Medical, and they were gracious enough to host this course. And obviously on the other side, you see me placing some zygomatic implants with some participants on a cadaver head and using pterygoids. Here we're using Dr. Garg's facility in North Miami. It's a beautiful facility. But we had a great setup and a great team for these courses. I'm hoping we can do more of these. This is the other slot course that we had done. Once again, cadavers with the Norris These are the Norris Premium kits here. We did some pterygoids and zygomatic implants. So now I'm going to show you a case, a couple of quick cases. I'm not going to go over all the surgical portions. Now, what about a case where you just have another failed all four and the lower? So this is a patient which has terrible dentition. Her maxillary teeth have been gone for a while. Mandibular teeth have failed, and she's a candidate for an upper or lower. So what I do for these cases is I use the Norris Tough implants. In this case, it's phenomenal. So it's basically the same implant that you use in as far as the zygomatic implant. The tip, it's like a Tough, but it's basically the same implant but much shorter. You get the same aggressive thread pitch, same phenomenal primary stability. So in this case, we did a double-barreled zygoma. Obviously, in this case, they weren't crossing each other, and this was further down the road. I didn't have that tendency to over-torque and then get a green stick fracture, but nonetheless, I'm just showing you here that we had the implants parallel and non-crossing, and they're at least a centimeter apart, so you get good AP spread. In this case, you see the bottom and top being done at the same time. So these cases are a little more challenging. I placed 5 Tough implants in the mandible and 4 zygomatic implants in the maxilla. Patient wakes up with a beautiful smile. So they go from that to this. And this is a great service. And obviously this patient, you change their facial profile a little bit, but nonetheless, I mean, the improvement is dramatic. And this is prior, they still don't have the final restoration. Sometimes if you make your temporary restoration too good, they're not going to come back for final. So you got a beautiful smile, and I think what we'll do in the final, I think her doc and I have talked about is giving her a little bit more bulk because she's not having as much incisal show on smiling. But these are all things that are corrected in the final. I have one more case. It's a very extreme case I want to show you. This lady had such a flat maxilla that she could no longer wear a denture. You can see there. The maxilla is completely atrophic, and there's nothing for her there. She can't wear anything. So what do we do with a case like this? We do a quad zygoma, and this is her smile. She's done phenomenal. Now, what about complications of zygomatic implants? So this is an older case that I did. Patient had, cutaneous fistula 5 years after placement. Well, now, why is that? So in this case, I had done the traditional, Nobel implants in the past. In order to get primary stability, I had to come out bicortical because, the burrs, they don't allow you to under-prepare the osteotomy. If you under-prepare it, the implant just spills. It's not self-threading or self-drilling or self-tapping. So what happens is you basically have to get bicortical stability. So what do you do in a case like this? This is an awful complication to have. So you have to open up this fistula and do an apicoectomy on these implants and then debride all the soft tissue. And obviously that's the only way to fix this. The implants are completely integrated. You can't do anything else. So what we did with this implant is I went in there. You can see I flattened out the implants with a big round football-shaped burr and completely flatten out that area, irrigate it like crazy because this generates lots and lots of heat. And you can see the patient now, 2 to 3 months later, completely healed. Now, this is another patient. This is not a complication of mine, but look at this patient. This patient had zygomatic implants done, and look what they developed. They developed a massive oroantral fistula, and they have all this granulation tissue here. I have not repaired this, but this patient is going to need a free flap or a temporalis flap. So this has to be done at the hospital. We have to remove this restoration. We have to remove the implants and do a temporalis or a radial forearm free flap. I've given the patients both options. Well, look, he's developed a terrible infection here. So not only they've damaged the buccal fat pad, he's developed a chronic infection here, but he's also got an oroantral fistula. This patient was referred to me, and obviously, this is a very tough complication to deal with. Either one, the oroantral fistula or the buccal fat pad infection. These are both tough things to deal with. I mean, this is not something you can close with a buccal fat pad anymore because the buccal fat pad is completely infected. So this patient needs removal, everything, and you have to go back to square one. This is another case that was just referred to me, a patient with an oroantral fistula, and unfortunately they had attempted to close it with a buccal fat pad 4 or 5 times, So I basically assumed, I said, well, let me try it one more time with a buccal fat pad. So I went in there and completely mobilized the buccal fat pad to the best of my ability and freed it up and closed it primarily. And I'm hoping this takes and this stays because, the buccal fat pad, usually I can mobilize and bring it all the way to the midline. But because this thing was so scarred, there's not much I could do. Now, if this fails, what do I need to do? Then I'm going to have to do a rotational flap from either the anterior maxilla, bring all this over, or do a tongue flap. And a tongue flap is a hard sell to a patient. But, this patient was referred to me to get this closed. And if we can't close it with this, then we have to do a tongue flap. There's really no other options. Now, this is the worst orbital penetration. This is a patient that had zygomatic implants done elsewhere and was referred to me. Luckily for this patient, even though the implants engaged the floor of the orbit itself is not penetrated. The orbital floor was completely penetrated inadvertently. So this patient's almost a year out and has had no issues. But some would argue about going in there and taking out the implants just to avoid any future issues, because that periorbital fat and muscles, you can get some shrinkage and then the patient can develop a problem. So we've decided to go back and remove these implants because to avoid the risk of future complications. So like I said, zygomatic implants are a great service for patients. There's a lot of great things we can do, but you also have to be aware of pitfalls and complications. And I think that was it. So this is our future courses. At the Florida National Dental Congress next year, I'm doing a hands-on course, the FNDC. It's June of 2021. We were supposed to do another one this April in Phoenix, Arizona, with the Western Regional Dental evaluation exam, meeting, but that was postponed because of the pandemic, and I think that's going to be rescheduled. And I think with that was actually my last slide. I want to thank everyone. And let me see if I can get to some questions now. I know there's 12 of them. Let me go back here and move this. So you mentioned the great cell taper threads. So actually, yeah, that's a great question. So the implant is you can place the implant with a handpiece. So basically, great question. So you're asking, you're not searching for bicortical fixation. What's the parameter for primary stabilization? So basically, just like any other dental implants, my ideal torque value is going to be at least 40 to 45 Newton centimeters. I can place these with a hand driver. So if you go back and look at the kit, there are some. I apologize. Give me 1 second. There are some drivers that you can place on your handpiece to place the implants, and you can torque it in. But I've gained more experience by using the Norris hand driver, but that's how I know. Let's look at the question. You use virtual planning to decide the accurate spot for the placement. I don't use the virtual planning, the e-zygoma. I have not, but I will be using it. I actually think it's going to be a phenomenal service for patients. I think for a few of my patients that I did not use it for, it was a matter of cost. But I think the virtual planning is a no-brainer. And for the beginning surgeon, I think the easy plan and the e-zygoma that Norris offers, it's a no-brainer. If you haven't done these before, I would definitely encourage you to use that technology because it's available. And I will be using it for my next course because I want whoever comes here to get that exposure as well. If virtual is not available, how to safely place implants avoiding the infratemporal fossa and the orbit? Well, so that's a great question. So basically, I plan my surgeries ahead of time using my CT scan nonetheless. And during surgery, as I showed you, I take that the measuring device, I place it into my osteotomy, and I want to feel the tip of it from outside. So I basically place my finger on the outside, and I make sure I feel the tip, or it hits my retractor. So if someone has a really fat cheek, you're not going to feel that, but you'll feel it hit the tip of your retractor. So I take every step along the way to make sure that I don't hit that. I think I answered the next few questions. Let me see here. Where did I train? I trained at the University of Miami. I trained at dental school at University of Florida, and my medical school at University of Miami in oral surgery, and my fellowship at the University of Miami. I think I answered. Thanks for an elaborate answer. You're welcome. Do you prepare bone when suturing for flap fixation? So, in general, I don't prepare bone when I'm suturing for flap fixation. However, that is perfectly fine to do. And I have used a PRF membrane over my buccal fat pad in the past, but the buccal fat pad is so thick and robust. So you can take a PRP membrane and put it over there. And so someone asked, why do I preserve the midline? As I mentioned, I preserve the midline because I want to make sure I can suture that buccal fat pad to the anterior portion of the maxilla. How we remove a disintegrate implant that is too close to the orbit? Oh, so actually, interestingly, I've had to remove a couple of implants that were close to the orbit in the past, and you very, very cautiously back that implant out. Now, if you can back that implant out, you either have to leave it there or take an infraorbital approach, like I'm treating an orbital floor fracture, and then I place an orbital floor retractor into the orbit to protect the orbital contents and perform an apicoectomy on that implant, because at least 4 or 5 millimeters of that implant is in the orbit. So if it doesn't back out, then I basically will do an apicoectomy on that implant as well, keeping in mind that I'm going to protect the orbit with an orbital floor retractor. Total maxillectomy. So I actually, it's a very good question, Dr. Rodriguez. So I have placed zygomatic implants in a patient that have had a total maxillectomy after radiation therapy. And that's the only time that I've had a failure in the last 3 years. So I had one patient that of the 4 implants I placed, he lost 1 of those. So it's a risk you have to take. Now remember, depends on the amount of radiation therapy they got, because maxillary osteoradionecrosis is extremely, extremely rare. And the only time I've seen maxillary osteoradionecrosis is in a patient that got about 8,000 centigrade of external beam radiation. So it's very, very rare. So where did I train for zygoma, and do I use PRF membranes for the sinus? So, you know what, here, it's a very, very interesting story. I did a fellowship with Dr. Robert Marks with tumor and reconstructive surgery at the University of Miami. So when I was out in private practice, I was doing a lot of all-on-4s. And in my very, very first case that failed miserably because I was using these 3i tapered nano implants that had a high failure rate, I had no choice but to learn and teach myself. There weren't a lot of docs doing training guys out then. Back then, Dr. Tom Balshi was training docs out in Pennsylvania. So I called him, and he said, listen, if you can do a pectoralis major flap, you can teach yourself to do this, or you can come here and have me do it. So I actually taught myself then, and over the years, I have learned a lot. So I think a lot of the docs out there have obviously learned it from. I've taken some courses with Dr. Edmund Bedrosian, which is a very good friend and a phenomenal surgeon. So if I had taken any formal courses, it was with Dr. Balshi and with Dr. Edmund Bedrosian, which are 2 of the pioneers in the field of zygomatic surgery. But I'm pretty much self-taught, but I owe a lot of what I know to them. So reposition the buccal fat pad. I have not seen any unforeseen cosmetic issues whatsoever on these patients. Because remember, the buccal fat pad is very robust. It has multiple lobes. I'm just taking the most medial lobe, which is not that vital to the cosmesis, and bringing it over to cover the cylinders over the implants. Let me see. I hope I answered every questions. Like I said, if I did not, please feel free to send me an email or a message. So I said I answered. Oh, there's 4 open questions. What would be the optimum torque? Like I said, the optimum torque is at least 45 Newton centimeters. I always get more than that because you're placing this implant into dense D1 bone. there's no way you're going to get minimal torque on these implants. Key is not to over torque it, obviously. I think I answered Dr. Mohammedi's question. Thank you for signing in from Iran. I really appreciate it. I know the time difference is very vast. I know a lot of people sign in from Iran, India, the Middle East, and I appreciate you guys staying tuned for so long. Okay, kind of this last one. How long after radiotherapy do you recommend going for zygomatic? That's a great question, Doc. So obviously remember, with radiation therapy, anytime I have a patient that is undergoing radiation, I prefer to place the implant within that first 6 months, before that, that golden window of opportunity. Some people say it's up to a year, because remember, over the years, the effects of radiation, it's a gift that keeps on giving. It can actually get worse over time. And so I prefer to do my implants very early on, before the deleterious effects of radiation kick in. Now remember, people get radiation mucositis, radiation burns in the first 30 days. So I let that go away, and then I do my implants afterwards. Now, with zygomatic implants for head and neck cancer cases, I invite you can send me an email, and I'll send you some cases that I've done. Those we do not do immediate loads on, just because it's very difficult. They're wearing an obturator. That's the only time I don't recommend doing an immediate load on those cases. However, I do try to do it early on, and I know, even though it's kind of objectionable to some people, a lot of people still believe in using hyperbaric oxygen therapy for these patients. So I still put them through hyperbaric oxygen therapy. So as far as my courses in Arizona, if you have a valid dental license somewhere in the country, we can get you a 1-week temporary license. And actually, what happens is, you can, as long as the patient is not paying for the services, your tuition covers their expenses, then you can actually participate and place the actual implants under my supervision on the patients. So it's great. The state of Arizona somehow had this built into their dental board, where if you have an active license somewhere in the country, you can get a 1-week license. So it's great. As far as the type of occlusion, the temporary prosthesis, it's basically a flat plane occlusion that's determined by the restorative doctor, and basically we remove all interferences and centric from them. And what about malpractice? So actually, that's a good question. Your own malpractice company will cover that for these patients, for any patients that you treat during that week. So basically, you just tell. I mean, it's like anything else. If you're some people have licenses to practice in multiple states, and what happens with them is they should cover you, because when I do my courses, I go to Florida and I do live surgery there, and I work on patients. My own malpractice company covers my my malpractice. So I think you should be covered. And I think Dr. Villarreal, yeah, I think I answered that question, but I think are there any? Hopefully, I didn't leave anyone unanswered, and if I did, I apologize. Yeah, I already knew that. I think you saw the surgical steps. And like I said, if anyone has any questions, I'm more than happy to answer them. With that, I thank everyone. I think we had a great audience. They're trying to put in the code, but there's no option to put it in. I think if you have any questions, I would encourage you to call Norris Medical for your continuing education certificate. I think that's what the question was. I thank everyone, and I hope I added something to your afternoon. I appreciate your patience, and thank you for your being a great audience. Let me see, there's chat here, more questions. There are more questions, or that was what I already answered? Oh, yeah, I did.
Hi, and welcome to the 2021 Academy of Oral Surgery's Fall Symposium. I'm Dr. Carlos Mourão, the host of this program, and today I'd like to introduce our special guest, Dr. Gurian Demiragi. Dr. Gurian graduated in dentistry in the Faculty of Dentistry, Tirana University in 2003, and he's specialized in oral surgery and implantology, and in BWKH Berlin University Hospital of Charité, and he's also oral and maxillofacial surgeon. From 2010, master and later PhD in neuroimplantology in the Faculty of Dentistry, Tirana University. He's also a speaker in outside Albania in important events. He's also author and co-author of several articles in Albania and international magazines. It's a great pleasure to have you here today, Dr. Gurian, and I know that you will have an excellent presentation from you. The floor is yours.
Hello everyone, glad to be here with you today. Let me start with a small tribute for the hosts of this event. I hope really that you like. My presentation today will be about saving teeth and implants, which is the new goal that everybody should have. Because for every dentist, the ultimate goal should be that teeth and implants live till their life's end. So teeth and implants, to do so, need enough bone and soft tissues to support them. Implants in particular needs primary stability and also later on stability, and an acceptable emergency profile which would allow that it can be cleaned and allow them to be there for many, many years. The good thing is that patients are accepting implants more and more as a solution, but the problem is that everybody wants less surgery as possible, and they want more aesthetic results than before. Which brings us to the big question and the big, exclamation: bone sets the tone and soft tissue is the issue, which, as we know, is lost very soon after we do an extraction. So in 6 months, we'll have this dimension bone loss, as the colleagues suggest, but many other studies suggest similar results. So we need to turn to bone grafts and soft tissue grafts to regain what we have lost. And these are some of the reasons why we use these grafts. But what we look for in them? We look them to be with a short and long-term function, and possibly to turn over completely, to be a reliable scaffold, bioactive, to instigate remodeling. They should provide quick results, should be easy to handle, and to minimize the risks. Other indications to be considered are the grafting sites, age and state of the health of the patient, medications they are taking, smoking is also important, and also other stuff which has to do with the skills of the doctor that is performing the procedure, and also patients' consideration which are different, and they will make you choose one graft over another in order for us to fulfill them. What do we see in practice? Well, many times the graft is lost. We have bone recession. We have unpredictable results, short and long term. And what can we use? Allografts, xenografts, and synthetics have been used. and also autologous bone and teeth. The last one are the best accepted from everyone, but the last one has got also some, issues because you need some place to get them. And these are the places where we normally look for an autologous bone graft intraorally. Extraorally, of course, we can go on and search for them. How do you harvest the autologous bone intraorally? These are some of the instruments, and these are some of the old-fashioned instruments. One of my favorite instruments to use is this osteotome, which is called Unica. The beauty of this instrument is the fact that with small probing just before, without water and with small rotations, you can get plenty of bone from the implant site in form of bone chips, which then you can later use for other grafting procedures around the implant or even away from the implant site in order to restore as another one that I really like and enjoy using is the scraper. As you have seen before, I really like this instrument. It's easy, it's fast, and allows you to collect cortical bone to use for your grafting procedures nearby or in distance. The bone chips collected are really nice and very good, so the use of it is really to be considered. Another very good source of autologous bone grafting is the tooth. Of course, it requires a tooth which needs to be processed in order to be used, but this is really a good idea. So please, as you can see, there are about 20 million teeth extracted every year in the US. Please don't discard them and use them to do a graft, which is really good and in quality that equals the bone graft. So it is easy, and the procedure to do this takes about, say, 7 to 8 minutes, and afterwards you can transform it into a clean graft, bacteria-free, which can be used. If you want then to improve it even further, you can make it sticky tooth, as in this real-time video, in which you can see that the bone graft provided from the tooth, so the tooth graft, is then enhanced with unsettled fibrin from the BCGF procedure, which are crushed in it, settled clouds of fibrin, in order to augment them even further with growth factors and make it much better as a sticky tooth, which is a really good grafting solution that I've been using for many years now, and provides with superior quality, good stability, and can be used in all the possible procedures of grafting. As you can see here in real time, this graft is really mixing up and becoming sticky. So this is about it. Now it is all settled and you can use it in your grafting procedures. Well, everybody here will agree that the autologous way is the way to go. So not much is to be said to contradict me in this one. And also the autologous tooth has overcome some of the deficiencies of autologous bone, and is an easy procedure which why not everybody should use. And it's been tested for many, many years. And also the recent, techniques that have been used, like PET and root submergence, have also follow-up of many, many years. So it's good to know that this procedure is safe for your patients, and it should be used. Also, another ingredient that we need, as we said before, are the soft tissues. So these are the places where we normally look for in soft tissues. Palatal and tuberosity, maxillary tuberosity are the ones that we prefer. Also, displacement grafts. And everywhere where we can find some a quantity of autologous soft tissues, that is good to use. And many techniques should be used to improve what we already have. This one is soft brushing. This is a technique that allows us to stretch the fibers in order to make place for the new bone that we are going to place. You can then place other small soft tissue grafts. But first of all, you have to make place for this graft to be placed into mouth. We use a technique with a small incision, as you can see, the tunnel superiostal technique, which can allow you to place the graft underneath between the bone and periosteum in order for this to then be maintained and not to move from position. As you can see with the soft brushing kit, as before, in the small incision made, we make place for our graft of hard and soft tissues so that we can then have this small wound which can be sutured easily, and the patient is also happy because it will not cause him a big wound in his mouth. And for us also it's very nice because we can have this small incision to heal, and this will allow us not to have problems in the future. Normally we have very small problems with it. Source of autologous soft tissues are the fibrin clots that, as I told you before, I get with the BCGF system. So we get the blood from the patient, we centrifuge it, and it is divided in several compartments, or let us say several straits, stratificated in at least 5 according to weight. The first 2, or let us say the first 3, are the most important for us. The serum, which is very good to be used to wash the wound. The white buffy coat, which is the fibrin that we use often, and then directly connected to them are the growth factors and the CD34 plus, which comes from the blood. It's an easy procedure and it's done in like 10-20 minutes, but meanwhile we can continue with your surgery. Many doctors are doing similar procedures around the world, and everybody is giving it's going on with them because they are easy and they have a good performance. Some clinical cases, as you can see, I have extracted and used many years this grafting, so I have much to show about. And as you can see, there are many cases with sticky tooth. Some of them I'm going to demonstrate in this presentation. Well, as I told you before, the goal is to preserve the teeth. This one is one of the classical problems. We extract massive cyst. This one was from 21 till 26. And we also have got like 4 infected wisdom teeth. And the situation was furtherly worsened by the fact that the patient had non-occlusal trauma and hypothyroidismus. The patient diagnosed this case a couple of years earlier, but due to the fact that it was such a big cyst, she was scared, and many other doctors told her that she should go with big grafting, iliac crest, to get enough bone to fill this big hole, which in the moment when she came to me was with around 4.5 centimeters. But at the moment that the patient get this aspect, there is nothing more to wait. She started some therapy, some endodontic therapy before with these 3 teeth, 21, 22, and 23, which was done to, try to reduce the mass of the cyst, which, as you can see, is big enough. And this is the hole in 3D. But it wasn't successful. We treated the other 3, as you can see, in a very conventional way, nothing fancy. This is the measurement of the cyst in every teeth. And we had also a witness that thought that it was impossible, but afterward he became one of our, believers. So, as I told you before, I extracted the 4 wisdom teeth and simultaneously did some graft in order to make this like 16 cc that we needed. This 4 wisdom teeth provided us around 12, and the rest of it was biomaterial. And lots of BCGF clots. This is the cyst. As you can see, when we extracted it, we corrected a little bit the margins. As you can see, they are still sharp because we didn't want to lose the scaffold provided from this minimal bone. We treated the apexes, nothing important. Laser was also used to hygiene this hole, laterally a big hole. And this is the biomaterial placed inside. And we also placed a membrane, but this membrane was not to do something, because normally I don't use membranes, because BCGF clots are more than enough in form of membranes. But this one, as I told you, it has these sharp margins that I didn't want them to cut my soft tissues. So I placed this membrane, which is a simple collagen membrane, to protect this bone in order for me not to have problems during the healing. BCGF, lots of it. This is the wound closure, which is really important in this case. This is a situation at 1 month after surgery. We did an X-ray at 1.5. As you can see, everything is stable, and the CBCT at 9 months. This is the situation at each site, and as you can see, there is bone everywhere, and we lost none of the teeth in the procedure. At 1 year, we performed some treatment to these teeth with posts, fiber posts, and also other treatments in the other teeth, because we wanted to improve the occlusion. It's very important that you have a stable occlusion in these cases, so that we're not losing this tissue that we have. So this is the situation, and now the case is like 4 years old and is doing very well. The patient has no problems, is continuing with her life. Another case I started using in orthodontics with one of my approaches combined with Dr. Baruti. So we called it the Baruti-Demiragi approach for corticotomy. And this is one of the cases in which we performed also some bone grafting. As you can see, the frontal area in this patient, which is a doctor, is very bad, no hard tissues at all. And there is here this tooth to be uprighted. And so this is the uprighting device. We did corticotomy and bone grafting in the frontal area, as you can see. This is the graft, and this is covered with BCGF. And we did corticotomy here, partial corticotomy to upright this tooth. Is about 7 or 8 years old, this case. So as you can see, the follow-up is not so small in these cases of mine. And after the tooth was uprighted, an implant was placed, and we took a CBCT to see the improvements. And as you can see, there is new bone everywhere in this frontal area. So the situation is much better than before we started the treatment. An implant was placed, and then that was it. Another case with class 1 malocclusion, retained 13 and 22. Lots of other problems with thin gingival biotype, insufficient bone coverage overall. We decided to go with corticotomy with BCGF membranes covering and orthodontic treatment in the second stage and implant placement in the third one. This is the initial situation, but if you see the 3D and the intraoral pictures, the situation is much worse than it looks in the X-rays. So this is from where we started. Corticotomy with our method, covered later on with bone and BCGF membranes. This is suturing and going on with the orthodontic treatment, which starts immediately after surgery. After alignment, implant was placed, number 23. And this is the BCGF, this is the CBCT situation afterwards. As you can see, there is lots of correction to that initial disastrous situation. And this is the situation now, well, so to say now, because it's like 5 years old. And as you can see, there is much improvement in hard and soft tissue everywhere, and the patient can smile now. Another case, which is even more dramatic, a 13 years old patient, class 2 division 1, high angle, bilateral crossbite, anterior open bite, V-shaped maxilla, mouth breather. The frontal teeth has got a densification with vestibular roots exposure and bimaxillary in the frontal area. The treatment was RPE, McNamara type before, after split in the middle of the palate, extraction of 14 and 24, and then the treatment with the Baruti Demirati approach with sticky tooth and BCGF membranes. This is the situation before the treatment started. So as you can see, the maxilla is much too narrow to start with. So first of all, we started with expansion in the middle. This is right after it. And then we extracted the 3 rooted premolars. As you can see, 3 rooted premolars, which are almost impossible to move according to the orthodontist. However, in order to create space, they were needed to be removed. So I used them as sticky tooth and added some biomaterial as well. This is the corticotomy procedure, piezo, we use. As you can see, the sides are covered with biomaterial and then with membranes overall. Same procedure in the lower jaw. And then this is after the surgery. This is the maximum swelling that we have in these cases. So as you can see, nothing important. This is the situation during orthodontics, accelerated orthodontics, because every 2 weeks this orthodontic treatment is accelerated. And this is the situation afterwards. This is the intraoral one. This is then the aspect extraorally in the x-rays. And as you can see, there is new bone and new soft tissues everywhere. So the patient has got new life, since she is also a very young patient and she can laugh now with all her heart. Another patient in which I decided to graft, something that I do often is grafting the wisdom teeth after extracting them. But in this case, I wanted to graft the anterior mandible, which, as you will see, is very deficient in bone. The patient has undergone orthodontic treatment in her youth, and now the result is this lack of bone in the frontal area. These are the 2 wisdom teeth, lower wisdom teeth extracted. This is the sticky tooth provided. And this is the incision with the method I showed before. I placed soft tissue and hard tissue simultaneously. And as you can see, the situation in each tooth from 43 till 33 is much improved. There is new bone vestibularly that was not before. This is the situation in the x-ray at 6 months. So nothing was done. Another case, vertical fracture of 15 resulting in bone resorption, and also bone missing vestibularly in 16 and 14. We decided to immediately place an implant because the patient is a businesswoman and she didn't want to stay a minute without her teeth. So this is the fractured tooth. Endodontically treated tooth are used without problems for many years now, and I'm glad to be one of the first that starting using them, and also to publish a case with orthodontically treated tooth. Of course, you have to clean them well from all the rests of endo material before you start to use them, of course. So in this case, as you can see, there is bone loss also in these teeth, which I wanted to improve with my surgery. So we extracted the tooth pieces, cleaned very well. We detoxicated them with blue M gel, which I often use in my procedures. These are the tooth pieces cleaned and ready to be transformed into graft material. Some more biomaterial, blood and bone chips, of course, which I like to mention, but I almost always use, because since I told you that the scraper is one of the accessories in my surgeries, of course, it is some autologous bone to enhance the situation. So this is a situation. Cervical VPI was used to create this emergency profile, which is a 2-part system that includes the surgery and prosthetic part. So you choose the right surgical tool, and then you can make an helical abutment which is perfectly shaped as the tooth you are about to extract. And I used it, and this is then the situation afterwards, after we created the crown, also more blue gel. This is the situation. I added some some retromolar soft tissue graft because I wanted to improve it further. And this is the comparison in this teeth before and after grafting. And also this is the implant. As you can see, there is bone to support it everywhere. This is a result after the removal of the sutures, and this is healing at 1 month and at 6 months. As you can see, it is almost like the rest of their teeth. Another patient, 58 years old with periimplantitis, unconventional treatment, bone loss, vitamin D, avitaminosis. Well, as you can see, this is the CBCT and the 3D reconstruction. There is some bone loss, and the patient had complaints in this lower area. This premolar was not endodontically treated, and this was a bridge that was holding one implant and 2 teeth. So the implant was in the middle. Well, also there was big problems in the upper jaw, first quadrant. As you can see, these 2 teeth has got almost no bone palatally. Of course, they aren't so good, so well placed. But however, the patient didn't want to remove them for the moment. So I decided to go for it and decided to, graft it and try to save this teeth also. So this is the preoperative situation also in this implant in the lower one, number 46. We reconstructed the number 45, I believe, and number 47 was the implant in mouth, and we place another implant, number 46, sticky bone, and another implant, number 35, was placed. This is the cervical emergency profile. As you can see, very nice, very naturally shaped, and deep enough in this case. It's like 6 millimeters deep. And also we improved the bone in all the other implants, existing ones. As you can see, there is bone in both sides. And my new implants, of course, they got their share of bone, of course. And we also improved the bone in the frontal region so that the natural teeth are also held in position. And we are going to do some more grafting in the future for the upper jaw so that the situation is better and the patient has got his teeth for a very long time, possibly till the end of his life. So these are my implants. As you can see, the emergency profile and how deep they are. And this is the aspect, so how they look after prosthetic treatment of zirconia porcelain is finished. And this is the existing implant, which is, of course, much improved from before. Another case, patient, female, 62 years old, implant and bridges done 15 years ago with bone resorption in the entire upper jaw and some infections in the frontal area. So teeth from 12 to 23 were treated. Immediately was placed grafting and BCGF membrane. And afterwards, something occurred that I will explain you later on and needed me to perform a socket preservation. So this was the situation 15 years ago. And I placed a couple of implants 15 years ago, which are not what I should have done now, but however, for the time, they were okay. And the fact is that they are in mouth for 15 years, so I haven't got much to, complain to myself. However, this is the situation now. Like 3 years ago, as you can see, there is bone loss, which in my opinion is a physiological bone loss, and nothing to do with what we call, or what I believe should be called, periimplantitis. However, there is bone loss everywhere in the implants and also in every tooth, and some changes in the apexes of the frontal area, which I decided to treat simultaneously, laser cut, and then afterwards we exposed all the apexes, cleaned with piezo, and BCGF was also used. MTA was used in the apical areas, and then I performed some superiostal tunnels in the both directions, as you can see. And this is the soft brushing. And then afterwards, I started placing my graft with hard and soft tissues in the entire jaw, covering it with BCGF membranes and suturing it. Also Blue gel, as you can see after suturing. This is the post-op CBCT. And as you can see, those implants will be there for many years more. So also most of the teeth will be still there. And why do I say most of the teeth? Because we had a small problem with number 23, which cracked during this time. I can't know, but malocclusion was one of the things that was suggested to me that caused this crack in this tooth. So afterwards, I had to, extract it, a vertical fracture. I grafted it, added a little bit of biomaterial as well, and I did a socket preservation in this area and placed a provisory bridge for the healing times. And then the bridge was changed. It's not, so to say, the maximal aesthetic result, but the patient is like 65, so it's nothing that she cares about aesthetic in this moment. And of course, there are some other changes to be done, but the patient is unwilling to do so. So we have to consider that too. And the situation is now stable for like 3 years, and I have nothing to regret for my treatment. And now the implants are also stable. Well, this is the one case that is not something that I would recommend, but it is one case to show you what you can do with grafting nowadays. The patient has got only 3 weeks, so he had only 3 weeks because he lives abroad and didn't want to stay without teeth because of his job. But there was no bone in most of his mouth. The only teeth remaining to use was 17, 12 till 23, and 26, which were prepped, and I made a bridge out of them, which was provisory for my opinion, but till now it's still a solution for his mouth, and he doesn't want to place implants soon enough. But let me tell you what was going on. This was the situation a couple of years before he came, and this was the situation in the CBCT after 2 years from this panoramic X-ray. So most of the teeth here are boneless and almost gone. This is the CBCT cuts. And what could I do? I extracted them and flaplessly grafted with sticky bone, with sticky tooth provided from this teeth, after cleaning it very well, of course. Piezo was used, lasers, also Blue solution and gel was used to detoxify these areas. These are the teeth extracted. This is the sticky tooth that we had provided from them. We placed it, as you can see, flaplessly. And as you can see, the teeth are already ready to have a bridge over them. And also with the tunnel technique In the frontal area, I also placed some bone. This is the serum that I always use before placing the graft, because the serum has very good antibiotic properties, antibacterial properties. And of course, it also improves healing. As you can see, sticky tooth was placed also in the frontal area. And I placed this provisory bridge directly after the surgery. And within the 3 weeks, as I told you, without even removing these sutures, I placed this full mouth bridge in metal porcelain, which since he was going to come in 1 year, I wasn't sure that the provisory bridge will do the job. But this mistake costed me the fact that the patient is now happy with this treatment, and this is the X-ray he showed. He sent it me a couple of years later, and he came then later on, and this was the situation with these bridges. And he doesn't want to change it, but he had the small problem in the lower jaw in this area, number 43. And he wanted to, treat this infection here, which created this enormous hole. And I decided to treat it. And this is a recent treatment. And I did it also flakelessly. And this is a situation after my grafting, and of course, splitting the teeth together and creating the contact point here, because it's imperative if we want it to succeed. It shouldn't be loose. And I'm hoping to get a good result here also. And I'm hoping also that the patient will change his bridge to a couple of implants in each side, so that his situation is stable then. Well, another case, a patient 60 years old with unilateral crossbite, is a bruxer with a deep bite causing abrasion. He is also a diabetic and with hypothyroidism, and he's got like 4 infected teeth. And we decided to extract them and to place bone everywhere and to treat him orthopedically, so full mouth rehabilitation, so to change the situation he is in for the moment. This is the intraoral view. As you can see, it's something very bad. The pre-op CBCT shows us this situation. There is also bone loss caused by malocclusion. And this is how he closes his mouth, as you can see. Since he had pain, we provided with an emergency bite. And then after a couple of months, I decided to go with my treatment. Botox was, of course, used to, reduce mesenteric strength, so to say. And this is the full rehabilitation, which started before surgery. I extracted the teeth, as you can see, added, of course, biomaterial and bone chips, because it's a big quantity of bone to get. This is the post-op situation. Directly afterwards, the provisories were placed in the right height. So he's got now a good third, a good dimension in this in the lower third of the mouth. This is after 6 months. As you can see, there is new bone formation everywhere. And we placed our prosthetic treatment in both jaws. He didn't want to get implants. And since it was a full mouth rehabilitation, we had to agree. And of course, it's not that every patient should have implants. Teeth are good enough, I believe. And I'm going to show you now a couple of cases with periimplantitis. and finish with it. So, periimplantitis is one of the problems of our time. And of course, it's in many times, exchange with the natural bone loss that occurs in every patient mouth. But this one is a female patient of 30 years old that I know for like 16, 17 years now, because she came with a trauma, and this trauma caused her to lose her tooth, number 21. And then we treated her at the time. So this is the situation in 2004. We treated her, and this is the situation now. So orthodontics was used to create space for an implant. And since the patient was like 12 or 13 at the time, we placed this kind of solution to, mimic and make her have a tooth in her mouth. And then in 2017, when she was adult enough, we placed an implant flaplessly at the time. It was the trend. And as you can see, this is the implant placed. And the prosthetic treatment in 2007. This is then 2017 when she came back wanting, now she's adult, she is an architect, and she wants to improve her situation. So I decided to perform surgery with grafting in a tunnel technique with FGG, sticky bone, and BCGF to improve the situation in this implant. This is the FGG site, which I cover with BCGF membranes and then suture. And then we changed the prosthetic in 2020, so last year. As you can see, this is the situation pre and post operatively. And I also changed the situation in our, adjacent teeth, 11 and 22, of course. This is the situation now. As you can see, no bone with plenty of bone vestibularly. And this is then the aesthetic result we achieved now. So this is the before and after. Another case, the last one, patient 45 years old with periimplantitis in an implant placed like 10 years ago or so from me. And the abutment has been moving for 3 years, and the patient didn't tell me nothing till the moment that he came out, which was too late, and there was an enormous loss of bone. And he's also a hepatitis carrier, but just nothing else to show to his anamnesis. And I decided to do something that I have seen from another doctor done, but I haven't seen it done in a periimplantitis. And this time I decided to do it. So this was a situation like 11 years ago. I placed an implant. This was the situation. And then he comes around 1.5 years ago with a broken superstructure, which I removed, which left this situation here. Well, I tried to, justify my errors, so to say, in doing a bone ring graft from the wisdom tooth number 48, which had to be extracted. And this is the partially decalcified tooth ring after you remove the enamel. And the rest of it is used as grafting, and some more bone was also used, some more grafting material was used. So extraction, and this is then the situation after, sutures removal. And this is the situation at the CBCT at 6 months. And this is the intraoral situation. It was pandemics last year, so even though I wanted to get good pictures, it was very difficult. So this is what I've got. And I was hoping the patient to come back, but since, as I told you, the first time he didn't come for, like 7 or 8 years. It's not that I'm expecting him to come again. I called him several times, but not to be seen. So. Are you not entertained? I hope with this to have finished another top 100 doctors to be mentioned here, which says the socket preservation should be the standard of care and every socket has to be grafted every time, which I would agree. And with this nice old picture showing dentists at work and giving you some more personal information on where to find me, I'm finishing my presentation. I hope you really enjoyed it, and I thank you for your patience. Thank you very much.
What's going on, everybody? Hope you just enjoyed that CE course brought to you by the AOS. Been a fun weekend, great content. And as promised, we wanted to continue as part of this virtual event to showcase a lot of the great companies that are out there now, bringing to you products and services in an effort to be able to, help you grow your practice, serve your patients and all of that. So very excited and honored to have with me a colleague and a friend. I've got Brad Tittenzer, who is the sales director from Dental Warranty. How you doing, Brad?
I'm good, John. Happy to be here.
Awesome. Well, thanks for coming on. And I wanted to kind of hop right into it because I know you got a lot of great things to share. And I know the Dental Warranty team, you guys are doing a lot of great things for practices along the lines of, I like to call it peace of mind, right? Patients come in, they get work done. In many cases, they spend a lot of money on the work they're getting done in the dental practice, the likes of what they would spend on a car. And so I know what you guys have done is provided that peace of mind, not only to the dental practice and the providers, but also the patients. So I'd love to have you kind of hop in and talk a little bit about what dental warranty is.
Yeah, appreciate that. The game has kind of changed in the practice. The last 18 months or so, the world has been turned upside down, and patients are behaving a little different. They're acting a little different. They're asking more questions. It's not uncommon to hear patients ask, "Hey, how long is this going to last? What happens if this fails? Or if I lose my benefits, I move, get a job transfer." Patients are more mobile these days too. They're working from home. They can head out of town for a while. And so you kind of mentioned peace of mind. Again, the world's been turned upside down. Patients, if they're spending a couple $100 or several thousand on whether it's their mouth or anything in life, they want to know that their investment's protected, right?
Yep, absolutely.
And dentists are amazing at what they do. It is the best techniques, do all the CE, use the best labs, materials. They can see the best implants, any restorative, cosmetic, whatever it may be, but life happens. Believe it or not, patients don't always listen to what the doctor says. They might bite their fingernails. They might open things with their teeth, get decay, bar fights. We've heard it all. And then you're kind of stuck, with this back and forth on who's paying what at that point. Mm-hmm. So we found by just proactively talking about how great the dentistry is and the work that you provide for your patients, also let them know how you back it, how you got their back no matter what life sends their way.
Mm-hmm. Yeah, I love that. And I think you mentioned there's always that time where they come in, they get the work done. Practice is excited. Dentist is excited with the work that he or she has done. Patient walks out of there. And then, like you mentioned, life happens. And it seems like, Brad, it's always those after the work is done types of conversations that can tend to be the most difficult, right? Because you're seeing a lot of patients, they're coming in and out or what have you. And then nothing like getting that phone call 2 months, 5 months, 8 months down the road where something happens. And then like you said, you got to figure out a solution. I know that's what you all support practices with. So can you talk a little bit about, how it works, how the program works? I think more importantly, like who in the practice typically has these conversations with the patients in regards to discussing the warranty and things like that?
Got it. Yeah, absolutely. So, and kind of go back to your first point, patients are funny. They get this treatment done and they expect it to last a lifetime, even though they broke what God gave them, right? They're there for a reason. They get this treatment and they expect it to last forever. And heaven forbid something does happen to it, they expect the doctor to do it again for free, right? It's this weird expectation. So what's great about this is it sets those right expectations with the patients. So typically it's the treatment coordinator that would be just kind of reviewing kind of what the patient's getting, all their benefits there for being part of the practice, and then it includes a 6-year protection plan. We coach a team on how to best do that in a way that does help with overall case acceptance, just with added peace of mind. But we've got doctors that'll mention it in the back. Is make sure to talk to the front desk about this, right? This is great work, but I've seen things happen, so I just want to make sure that we've got you covered no matter what. So so it's typically those treatment coordinators, but another tool that we've built into this is kind of our loyalty and engagement tool. So when the patient has this warranty, their obligation is to come back in every 6 months or 3 months or whatever the doctor recommends to keep that coverage active.
Right.
Kind of going back to how things have changed in the office, it seems like if the wind is blowing the wrong way, patients will call and cancel their hygiene appointments. So this is just another tool that the team can use to say, hey, as a quick reminder, you got a warranty on that implant or whatever work it was. Let's make sure to keep you coming back in before this date so we can keep it covered.
Yeah, one of the reasons why I have loved what you guys are doing is because, as you know, Brad, the dental practice is one of those unique areas where you don't walk in and see a menu above the front desk that talks about the prices of the procedures, right? Like we get that when we go to restaurants and all these different places where they're advertising price. And when you mix in insurance reimbursement, and I mean, who even knows what things cost when you get them done at the dentist. And so I think that's been one of the toughest things for dental, professionals for years is just the fact that, that unknown world for patients. And so that lends itself, as you know so well, to then questions on the back end when things don't work. And you mentioned that. And so I think that's what's so great about what you guys are doing is that it's bringing that confidence to the patients on the forefront. To, I think, number one, stressing the importance of the work that's being done and the value of it, but then more importantly, life happens. So exactly. I think that's,
and
super
one thing
exciting.
I'll throw in there as well is it's been kind of interesting how valuable just having those upfront conversations with those patients is becoming. Yes. I got a doctor say, you know what, at this point, I don't even care if the patient buys this or not. The majority of them do, and it's great. It's a win-win for everybody. But even if they say, no thanks, I'll pass. No big deal, no cost to them, no cost to the practice. And it still sets those right expectations. So if, 4 years later, they bite into a peach pit or something happens to it, they come back in, they don't just expect the practice to do it for free at that point because, this has already happened. You get the bad reviews, the upset patients, threatening whatever they might say or do. That can be avoided by having these proactive conversations on the front end.
That's a great point, Brad. When I think about that in particular, a lot of times, let's call it like it is. It's the optics of the things that the practice is doing and saying on a daily basis to all of their patients to plant those seeds, which then in many cases, show up 6 months down the line, or like you mentioned in the reviews. I think to myself, we live in a world now where, family and friends and colleagues are talking to everybody. You mentioned this transient nature we're living in where people are moving from cities and with all the changes in that. And so there's a lot of questions about who do you use? Who do you go to? What dental practice do you go to? What have you? And all those little things like, hey, did you realize that in my dental practice, my dentist offers a warranty, gives me that peace of mind. And I'm glad you mentioned that because I think those things go a long way. And also, like you mentioned, the fact of them not worrying that if at that moment the patient signs up for it, at the very least, like you said, the doctor feels confident they mentioned it and they're aware of it, which I think is cool.
Exactly. And the patient communication is an interesting point too, because when you think about when patients talk about dentistry, it's really one of two things. If they're out to dinner with their friends or talking with their neighbors in the mailbox or whatever it may be, they are when they talk about their teeth or their dentist, it's because either their teeth look amazing, or because they chipped something, they bit down on something, or the kid knocked out a tooth or something happened, right? And that's we get a lot of referrals through patients because they say, "Oh, check out my doctor. They do great work, and not only that, but they back anything for the next 6 years."
Right.
And that's something too. I'll mention real quick is what we provide is it's a 6-year nationwide protection plan. So not only does it cover the patient right there at the practice, but if they do move or travel, it covers them again wherever they go. And this is something that the patient would actually purchase from the practice. So it's no cost to the team. to the office. It's based off just utilization. If the patient wants it, great. We get a portion of that percentage, and so does the practice. So it's designed to be profitable as well.
Yep. I love that. All right. So what we've done, everybody, is we've put Brad's email in the comments. So if you want to contact him directly, if you have any specific questions, he can help you with that. We also went ahead and put the dental warranty website. So we'd love to have you go visit them, learn more about what they're doing. And then of course, reach out to Brad. I've known this team for some time, and they're doing some great work. They really care about the practices that they work with. And it's been fun to watch, Brad, a lot more practices implementing this into their daily flow of what they do. And like you've mentioned, all in an effort to be able to provide that confidence and create a great patient experience, quite frankly. So I just want to thank you for coming on. Thanks for the work that you're doing. And again, everybody, be sure to learn more, click on the link, reach out to Brad, and find out what's going on with dental warranty. So thanks, Brad. I appreciate it.
Yep. Thanks, John. Thanks for having me.
You got it.
Hi, and welcome to the 2021 Academy of Oral Surgery Fall Symposium. I'm Dr. Carlos Moral, the host of this program, and today I'd like to introduce you our special guest, Dr. Ala Abu Sharia. Dr. Sharia, he's a medical doctor from Safari University, Faculty of Medicine, and he did his specialization in stomatology, and he completed his master clinical program in oral implantology surgery at New York University. Dr. Sharia is also member in Academy of Dental Experts at the Unimes University in Santos, Brazil. It's a great pleasure to have you here today, Dr. Sharia, and the floor is yours.
Ladies and gentlemen, good morning, good afternoon, and good evening to all. It's my honor to be today on the stage of the Global Summit. I'm a member of the AOS. I'm Dr. Ala Abu Sharia from Slovakia and from my dental clinic, Edemed, at Center of Banske Bystrica. Today, I'm going to share with you with my presentation about the integrated aesthetic in periodontics and implants case series. We start when an adequate quantity or quality of the soft tissue is available to secure a stable peri-implant environment. The implant surgeon must know the principles and techniques to successfully reconstruct these components. First of all, we need to know where we are working. In the cosmetic zone, we have some dentine, enamel, gingival sulcus, the free gingiva, where we have the keratinized tissue, and we have the free gingival groove. And the anatomy here, we are talking about the gingival fibers, epithelial attachment, cemento-enamel junction. And in the base of that, we have cementum, periodontal ligament, alveolar bone, lamina dura, mucogingival junction. And at the end, we have the alveolar mucosa. So the term of soft tissue integration describes the biologic processes that occur during the formation and maturation of the structure, relationship between the soft tissue, which is the connective tissue and the epithelium, and transmucosal portion of implant. Very important structure here, we have the periosteum, as we have the external layer and the internal layer, the compendium. The external layer, dense bundles of collagen fibers, parallel bone, and many fibroplasty is mixed with the gingival connective tissue. Combined inner layer, we have osteogenic and fibrogenetic connective tissue, loose connective tissue with the collagen fibers oriented perpendicular to the bone. And we have to know that the periodontal phenotype, thick and thin phenotype, like the thick biotype, particularly thick tissues, normal or reduced clinical crown, slightly marked gingival fistone square tooth shape. But the thin biotype, particularly thin tissues, increased clinical crown, well-marked gingival fistone triangular tooth shape. Development or acquired deformities and conditions, according to most of articles, mucogingival deformities and conditions around the tooth, soft tissue recession, loss of keratinized gingiva, decreased vestibular depth, aberrant frenum or muscle position. Then we have a gingival pseudopocket, inconstant gingival margin, excessive gingival display, and gingival enlargement. The dentist cannot always influence all the situations. Frequently is comforted with the hard fact and finds a situation in which hard and soft tissue losses have already occurred. At this point, it's necessary to act in a goal-oriented way in order to gain the lost tissue, and tissue around the implant must remain vital. Then we go for question, what's the goal? That 3D bone augmentation in the aesthetic zone, whether it's horizontal and vertical considerations. Many patients have already lost too much alveolar bone for ideal implant placement. Now we are talking about the bone augmentation. So in multiple implant cases, papilla have to be created artificially. But we have also the challenges of external GPR, space making, flap management, and we have lots of articles in surgical management of significant maxillary anterior vertical ridge defect, like in 2016. 3 current space management technique in GPR procedure. Still, we are talking about the bone augmentation. Now, the sausage technique, DPTFE, or the T-mesh. And the T-mesh, one of the most common used in the GPR, collagen membrane, and growth factors. Okay. When is peri-implant soft tissue management necessary? Now we need to talk about the soft tissue augmentation. Like we're talking about lack of inter-implant papilla, MJG displacement due to bone augmentation, insufficient keratinized tissue, recession during maintenance period, or tissue discoloration. By creating a stable soft tissue wall, this technique allows to compensate for the lack of bone support, reaching both biological and aesthetic clinical success. So we need the soft tissue graft, or we call CTG, connective tissue graft. The aim of these procedures is to integrate and describe the aesthetic in periodontal and implant therapy. The simple idea behind this presentation is to avoid unnecessary tissue loss from the very beginning. The result in a win-win situation for the practitioner as well as for the patient. And here I would like to discuss how to maximize function and aesthetics with attitude minimum, with the title minimum invasive approach. So we need to talk about the GPR and the GTR. So the guided bone regeneration typically refers to ridge augmentation or bone regenerative procedures. GTR, guided tissue regeneration, typically refers to regeneration of periodontal attachment. GPR and GTR are dental surgical procedures that use barrier membranes to direct the growth of new bone and gingival tissue at the sites with insufficient volumes or dimensions of bone or gingiva for proper function, aesthetic, or prosthetic restoration. Guided bone regeneration is like guided tissue regeneration, but is focused on a development of hard tissues in addition to the soft tissues of the periodontal attachment. At present, guided bone regeneration is applied in the oral cavity to support new hard tissue growth on an alveolar ridge to allow stable placement of dental implants. When bone grafting is used in conjunction with sound surgical technique, guided bone regeneration is a reliable and validated procedures. We would like to discuss about materials which we are using in these techniques. The augmentation material used are autografts, like tissue transfer from same person, allograft tissue from genetically members of same species. Other materials available, xenograft, tissue donor from another species, and autogenous bone, but not. When the bone density is quite low, the resorption of the grafted site in these cases can reach up to 30% of original volume. Studies comparing autogenous bone and bovine bone mineral in vertical bone augmentation failed to demonstrate significant differences between grafts in terms of bone gaining. Recently, we suggested a novel surgical technique for the treatment of challenging infrabony defects when gingival recession is an aesthetic concern. Further studies assess the using of bovine bone grafts in combination with the autogenous bone to decrease the resorption rate of the graft, to increase the long-term stability of the regenerated tissue, and to reduce the morbidity associated with the extraoral donor sites. Now we need to talk about the membranes. The barrier membrane is utilized in GPR technique to cover the bone defect and create sclotted space, which prevents the connective tissue from growing into the space and facilitates the growth priority of bone tissue. An added benefit of the membrane is that it provides protection of the wound from mechanical disruption and salivary contamination, and GTR as an alternative to resective surgical procedures to reduce pocket depths. Barrier membrane criteria should be as follows. Biocompatible, excludes unwanted cell types, allow tissue integration, creates and maintains space, provide the structure is easy to trim and place. Currently, there are two types of barrier membranes available. Non-resorbable membrane, the main types are the EPTFE, the expanded, the DTPFE, the high density, PTFE, the titanium mesh. So consequently, the EPTFE membrane acted as a barrier to soft tissue and speed up bone healing, which took place between 3 to 6 weeks. The biological method of osteopromotion by exclusion is good for the predicting ridge growth or defect regeneration. On the other hand, we have the resorbable membrane. There are many different types out there, but the main ones are synthetic polymers and natural biomaterials. The synthetic polymers are such that it is polylactic acid bilayer or the collagen-derived membranes. The membranes have been shown to significantly improve probing attachment level 1 to 0.1 millimeter and periodontal pocket depth reduction to 0.9 millimeter when compared to a placebo or control materials. Resorption rates ranging from 6 to 24 weeks, depending on its different chemical structure, and there is no need for a second surgery to remove the membrane. This will prevent any disruption to the healing process of the generated tissue. We have also the PRF, the plate-rich fibrin, which it belongs to a new generation of platelet concentrates with simplified processing and without biochemical blood handling, leads to the intrinsic incorporation of platelet, cytokinase, and glycogenic chains in the fibrin meshes, as we say, APRF. The results of the present study suggest that in the histological evaluation because of its biological components, PRF results earlier vessel formation and tissue maturation compared to the connective tissue graft. Now we're gonna talk about the sticky bone. After extracting the tooth, that we can grind it and we can use it with the PRF, and using of the sticky bone from the extracted tooth or the various bone materials, and this at the end, it's giving us the sticky bone. For example, the xenogenic debone graft materials derived from a non-human individuals, it's most used as a perfect substitute for autogenous bone graft. At this level, I'm using mix of this graft with the IPRF. Quick video how we are collecting. So establish the roadmap of the succeed of the implant. First of all, extraction and the technique of the extraction. Second, rules of placement. Third, soft tissue engineering. Fourth, placement protocol. We need to follow all of this. After tooth extraction, there is an apicocoronal as well as buccolingual attenuation of the affected segment of the alveolar ridge. Most tooth sites in the anterior maxilla have a thin facial bone wall. We'll start with cases. First case here briefly. In this case, I will discuss a 55 years old patient, healthy non-smoker, was referred to my clinic with a periodontitis, a chronic inflammatory disease of the tooth supporting structure, mobility grade 2 to 3, interdental pocket depth 3 millimeters, hypersensitivity, periapical lesions on the X-ray. After taking the OPG, then CBCT and options has been discussed with the patient, as well as a medical history. Patient agreed for the extraction option and full upper jaw rehabilitation all on 6. Immediate implants after extraction integrated with the use of GPR and GTR. Patient has been recommended to be without a provisional at least for 3 months until the taking of the impression for the final prosthesis. Treatment plan. Anesthesia was applied for the full upper arch. Horizontal incision is carried out at the base of the interdental papilla, extending one tooth mesially distal from the infrabony defect. A traumatic extraction done, a full thickness trepanized flap is then elevated, and the remaining facial gingiva is deepitalized with the atraumatic surgical extraction for all the upper teeth. Again, IPRF and APRF are ready to be used, having also the membrane, having also the mucomatrix, everything is ready for the surgery. The defect is degranulated and the socket has been scaled and cleaned with the bezo surgery. The treatment of the condition is largely based on the removal of the local factors and restoration of the bony architecture. The buccal flap, periosteum, is dissected and the flap is mobilized and coronally advanced to a level more coronal to the CEG, equalized for alveolar architect. I'm using here the parallel direction plan for implant insertion. We have also the digital, but in this case, we went for the manual one. The socket is now conditioned and rinsed with the saline solution. Sometimes we use also the glycerin. Tension-free primary closure for the interdental papilla is achieved. Full thickness of soft tissue graft was taken from the donor side palatally on the both sides. deepithelialized, and implant placement after checking all the measurement and stabilities. Insert plan with the zone of labiobuccal dehiscence. Bone augmentation of stick bone, mix of autograft and xenograft with IPRF made from the blood of the patient, filling the resultant cavity and covered with the soft tissue graft taken from the donor side, free gingival graft, and all covered with the APRF on immediate healing cap of the implant. CBCT at 3D postoperative. Finally, adaptation of the flap and fixation with the sutures. The vertical releasing incision are closed with the interrupted sutures and internal horizontal matrix suture. Postoperative mitigation was prescribed for the good results, usually explaining the amoxicillin. Most of the time the augmentin, and sometimes for the anti-edematous and some painkillers. According to many references, 50% of implantological treatments required a combining augmented procedures. And this picture is 2 weeks post-operative. Patient after completing of 3 months post-operative, and impression was taken, sent to the lab. Arriving of the lab work. Patient after completing the 3 months post-operative, appointments, fitting the appointments in the right position, and the bridge fitted in. Post-operative OPG taken after bridge cementation. Full porcelain Boden bridge done on the lower teeth after completing full periodontal treatment. There has also been big change in the patient's appearance, and he continues to be happy about long-term stability of his implant treatment outcome. Very important thing, as we see in the lower, we have a tooth, so the tissue capsule of the subcrystal gingival fibers that separated the lesion from the lower bone. To avoid this, and with the upper, to avoid the inflammatory infiltration of 2 to 3 times size that of the periodontal lesion and reaches the bone in the area interdentally. To avoid these complications with the upper implants and the lower teeth, a regular maintenance every 3 months was obtained by our dental hygienist. This technique describes a method to regenerate tissue. Tissue reconstruction achieves good and predictable result in most cases. The aim of this work is to integrate and describe the aesthetics in the periodontal and implant therapy. So we go now for different technique, different case, and this is case 2. Baseline situation: this young, healthy, non-smoker, 30 years old lady came to my surgery with pain and slight mobility of the upper anterior maxillary teeth, pocket depth 3 mm, bleeding on probing, patient even not happy with the crown shape and size done by her dentist, as well as gum shape. OPG shows periapical lesions and root resorptions caused by the inadequate root canal treatment, with cyst around the 1.2, 1.1, 2.1, 2.2 for a long time. Therefore, an implant-based solution was the preferred option to protect the neighboring teeth and to treat the gingival defects. As we see in the X-ray, so the extraction in the anterior 6 cm needs to be done atraumatic and carefully. Evaluate residual bone peaks or attachment apparatus of neighboring teeth. Free gingiva is released here after giving the local anesthesia, horizontal and vertical release incision done, the full thickness flap, tension-free, a traumatic surgical extraction done on the upper anterior maxillary teeth, socket preservation, keeping the bone architect and the residual bone ridges. Same thing, bezo surgery. The socket has been scaled and cleaned with the bezo surgery, socket excavation and irrigated with the saline and local antibiotics. Immediate implant inserted in position of 1.2. And 2.2 with a buccal defect. The bone loss around the implant, and we can see that there is a space. In this case, I decided to do the GPR and some of the GTR with the other material and techniques than the free gingival graft and bone harvesting from external oblique line of mandible. Minimum invasive surgery, one-stage technique. So, blood was taken from the patient to be used as a PRF, as a membrane replaced by poncho technique. IPRF with the bone D, 100% natural mineralized bone for sticky bone. And here we see that immediate healing cap ready with APRF membrane as poncho and sticky bone already to be replaced, ready to be replaced. Okay. Augmentations of the defected area by sticky bone filling and covered all the resultant cavity. Finally, using the Mocha Matrix X soft tissue graft, porcine collagen produced from porcine corium. In this case, I used the 2 layers because we know that one layer it will be absorbed by the bone, and the other one I suggest that it will be resolved by the gingival side. Double layer of Mocha Matrix soft tissue graft affixed on both sides by the lateral sutures, adapted and placed on the vestibular area to cover the augmentation and good adhesive buccally for thick mucosal gingiva. Tension-free primary closure of the interdental papillae is achieved using a non-resorbable EPTFE, internal horizontal matrix suture, and simple interrupted non-resorbable suture. Post-operative medication was prescribed for good results. Finally, the vertical releasing incision are closed with the accurate sutures. The papilla preserved and placed in the right place for adaptation and forming of keratinized tissue around each implant. Post-operative CBCT and 3D implants in perfect position, high stability, clean bone, established GPR and GTR. Result after 4 months. Buccally has keratinized tissue and alveolar mucosa, stable tissue, and coronoapical with the increased thickness. Pink and white after 4 months with a great gingival attachment and good aesthetic results on both sides. And we go for the third case. Still, we are talking about the integrated aesthetic. So finally, my last case of integrated treatment of the implant in cosmetic zone will be a single tooth replacement by partial extraction of a natural and atraumatic single tooth in the anterior maxilla, PTE, partial tooth extraction, or we call it socket shield technique, SCT. This case of 45 years old lady, economical lawyer, lost crown with a fabricated post of tooth 1.1. It was fitted with a provisional prosthesis by her dentist. PA X-ray shows tooth 1.1 with RCT and fracture of the fabricated post in the root. But we have good soft tissue and stabilized gingiva, healthy bone surrounding. So this case suggested to be done by a socket shield technique or partial tooth extraction, as implant-based solution was preferred option. Local anesthesia was applied in the surgical area using special kit and burrs for this technique. Is especially important to remove the palatal part of the root and to remain the buccal part of the root in the socket with a minimum invasive type of surgery for socket preservation. Retract the gum gently buccally, trim the cervical part of the buccal root, clean the socket from any debris, and irrigate with the saline and antibiotic. Then implant inserted in the site with immediate healing cap. Post-operative CBCT shows perfect positioning of the implant with the high stability. Good tissue surrounds the implant, including the buccal shield of the root, as well as the position of the healing cap. Furthermore, it's offered the operation of shaping the contour and course of the gingival margin around the implant and to influence the maintained development of the papillae by appropriate configuration of the interdental space. Without bone augmentation and the natural biology to work, at this stage, resorbable APTFE internal horizontal matrix suture replaced. According to my reference, 50% of implantological treatment required combining augmented procedures. Some articles were talking about filling this gap with some grafts. After healing, removing the healing cap, impression taking. I did that with the scanner. I have the Medit i500 scanner and scan body. So then the prosthetic crown fabricated and fitted by screw and torque was checked. These are the results obtained based on a randomized clinical trial trial done to compare the stability of augmented bone regeneration and simulations with the dental implant placement in the aesthetic zone in terms of facial bone thickness. Always we are thinking about minimum invasive and how to solve problems in a simple and elegant way. Finally, long-term maintenance to deal with the peri-implantitis. Take-home message: GPR and GTR are a sensitive operator technique, and the important factor of the success of these kind of surgeries is the level of the experience and the skills of the operators. New learning means repetition, practicing, and learning more theories. Thank you all, and nice to meet you.